The system working?
Yeah.
Good afternoon, everyone. Let's call this meeting to order and ask everybody to turn their cell phones off, including myself, or put them on no ring before we forget. Although the one we had last time, I think from this lady, was it was a very interesting one, or I wouldn't have mentioned it. Your ring. So, thank you, and I'm glad to see you back again. Let's get started. We have a full program for you today, and we'll start with Jennifer Barkin. Dr. Barkin, you want to come up and introduce yourself? Tell us who you're with and your job.
Hello, can everybody hear me?
Okay. Yes, ma'am.
So today I came to talk about something I'm very passionate about, maternal mental health, and I want to thank you for allowing me this time to express my thoughts about it. So a little bit about me, and not because I want to tout my credentials, just to give you some context for my work. I'm a University of Pittsburgh prepared epidemiologist. When I started to get close to needing to identify a dissertation topic, I knew I wanted a mental health focused dissertation topic. So I was lucky in the fact that a woman named Kathy Wisner, who's one of the pioneers in this area of postpartum depression, postpartum anxiety, and the treatment of it, was at Pitt at the time, and I was introduced to her, and she said, you know, we have lots of measures that assess and evaluate depression. But when patients present for treatment, they don't say, hey, I'm here because I want to get a 9 on the Edinburgh Postnatal Depression Scale. What they really want is to function better. So that, she said to me, we need a measure. We need a patient-centered measure that is applicable and doesn't take forever and that would work for women. So my research I am now an associate professor at Mercer University School of Medicine. About 7 years ago, I was recruited, and they said, we really need maternal child health. I fell in love with the campus. I saw a lot of opportunity to do clinical research, and so I brought my family to Macon, Georgia. To date, my research program is focused on perinatal mental health with a specific focus on maternal functioning. So why am I here today? To talk to you about two things. The thing I get asked to talk about most often is my intellectual property, and that's the Barkin Index of Maternal Functioning. I talk about it ad nauseum, not that I don't love it, but that's one of the things I want to talk about. And I also want to talk about the context that it fits into, which is the state of maternal mental health in the United States and Georgia. So I kind of already mentioned that the core rationale for needing to measure functioning is that the goal of medical care for most patients today is to obtain a more effective life and to preserve functioning and well-being. And I've used that quote more times than I can count. So when we embarked upon this journey of developing the Barkin Index of Maternal Functioning, we had some core principles that we wanted to guide the development. We wanted something that was patient-centered. And what I mean by patient-centered is that a group of us in academia didn't kind of go off in a room and generate the content for this questionnaire. We wanted to ask postpartum women and get them to define what poor and optimal functioning look like. So what is a good day for you and what is a bad day for you? And tell us about everything in between. So we interviewed 31 new mothers, and we ended up with a very robust qualitative data set that allowed us to kind of suss out these domains of maternal functioning. We also wanted it to be applicable in various settings. So, there are lots of measures that you can score on a continuous scale and pop into a research study, and they get published, and they might reach a larger audience, or they might reach a very narrow audience of academia. But we wanted something that was applicable in both research, clinical settings, community-based settings, and one thing that was sort of a surprise that it ended up being picked up in a commercially sponsored research. That was a big boost to its visibility and really to my career. And it's been really interesting to watch it play out. The other thing, we wanted concise wording. There was one measure of functioning that was developed a while ago. It was great work for its time. It's very long. It makes a flawed assumption in the calculation of the total score. And it couldn't, if you were a woman who just had a baby and you had your kids in tow and you're at the OB office and you've got, paperwork to fill out, that measure was going to frustrate you. So we did not want to do that. We wanted something that was very easily administered without convoluted item wording. And most importantly, we wanted to tap the experience of new mothers. So sort of some milestones in the trajectory of this functioning work is in 2010 we published the development paper. From then till now, it's been validated and validated and validated. It's being used in multiple other countries and multiple settings. It's been translated into 20 languages. And like I mentioned, sort of one of the key moments is when Sage Therapeutics picked it up as an outcomes measure in the clinical trial of brexanolone, which is the first ever medication specifically for postpartum depression. So that was a huge boost in visibility. And the data, I'm starting to see data from it. And what's really encouraging is that with the intervention, I'm watching the functioning scores climb. And I was told that, which is what you would want it to do. If it's measuring the right thing, you want it to be sensitive. So that's upcoming. Their main outcomes paper is going to come out soon. And what they told me is that the functioning data will be published in that main outcomes paper. So what does it do? It assesses functioning, not mood. When people have interest in it and ask me, how do you use this? Or I've had people suggest, this is more practical. I'm going to swap out the depression measure and I want to use your measure. I advise no, because it measures management and new motherhood. It does not assess mood. Depression measures, the Edinburgh Postnatal Depression Measure, which is the most famous one in the perinatal mental health world, it assesses mood. So there's a question on there about suicidal thoughts and self-harm. That is really important. So if there were interest in measuring functioning, I would always say it's a complement to depression assessment, not a replacement. What does it measure? So when we were talking to these women, what came out as important to new motherhood was, of course, social support, management, mother-child interaction, infant care, self-care, which always, always, always lags behind infant care. Women are good at taking care of the baby, not so good at taking care of themselves. Now, this is a continuum. I think every woman struggles with that a little bit because, you're supposed to be the super nurturing mom that puts the kids first. But, if you're running on empty, you're not good for the entire family. Because, we know that, and this is no disrespect to dads, my husband's in the audience, the family keys off the mother. The mother is the one that remembers the dental appointments and knows that everybody needs a flu shot. So they kind of they're the lioness of family health. One thing, so I get testimonials about this all the time, and it's affirming for me. I hear it from psychiatrists, women, people that want to administer it in a community-based setting, and they'll tell me, I love this because it really gets at the core concepts of what it's like to be a mother and be juggling, recovering from childbirth, and all of these other management issues. You're the CEO of the household, and we feel like it really gets at that. One of the most striking things that was ever said to me was in downtown Macon, we were administering the Barkin Index to low-income women and postpartum women. And one of the women, after she filled out the Barkin Index, she looked at me and said, thank you for this. No one has ever asked about me before, I feel like that really encapsulates the problem. In general, nationally, we focus on the clinical outcomes of the pregnancy, the baby's weight, premature or not, your C-section scars, the healing. That's all super, super, super important. But the mom's mental health, which is really related to physical health and family health, is also incredibly important. So why is the Barkin Index or the Edinburgh Postnatal Depression Scale, why is any of it necessary? That's because perinatal mood and anxiety disorders are the most common complication of childbearing. So the CDC estimates 1 in 5 to 1 in 9 for postpartum depression. The most frequently touted one I hear is about 1 in 7. Perinatal anxiety is just as high. And if you talk, canvass randomly and anecdotally doctors, both OBs and pediatricians, I always say, whether they're doing a valid assessment, thorough assessment or not, I'll say, when you see your patients, what do you see more of, depression or anxiety? And most of the time they'll say anxiety. And there are others that are less common, like OCD, PTSD, postpartum psychosis, which is rare but can be fatal. And what about the consequences to the mother? So it impacts her physical health if she's affected by a PMAD, which encompasses postpartum depression, anxiety, and all of these. It's an umbrella term for mental health conditions in the perinatal period. It affects her interaction with the healthcare system, utilization, her quality of life, her relationships, sexual functioning, and risky behaviors. So women that are postpartally depressed, on the whole, are more likely to engage in risky behaviors. Well, what about the dad? An emerging area of research is postpartum depression for the dad, and women get a little bit territorial about this, like, this is my condition. Get out of the way, guys. But what we're finding is for women that are depressed, 25 to 50% of the time, the dads are also depressed. And why would that be? Caregiver burden, right? You've got this new great thing, and it's supposed to be working out fine, and my wife is crying constantly. Men are less likely to seek help. It causes marital difficulty, suboptimal bonding, and men will report feeling overwhelmed, isolated, stigmatized, and frustrated. So what about the baby? Infants of mothers with PPD, by age 1, that's associated with failure to thrive, attachment disorders, developmental delays, and behavioral issues by age 1. So I don't know how widespread this research is yet, but over the past 10 years, research on fetal programming has sort of exploded. And what that tells us is what's going on with the mother not only affects the baby once the baby's born, it affects the developing fetus, with male babies being disproportionately affected. So there's a clear influence. The research is at the point that we can say there's a clear influence in maternal mental health and the development of the fetus. So why I went over all the family members is to reiterate the point that it's classified as maternal mental health. What it really is family health. If the mom's not doing well, the baby is probably not doing well, and the whole family unit is struggling. What about cost? The first ever study was done in 2017 and concluded that PMADs are costly and have multi-generational consequences. The estimated cost for all births in 2017 was $14.2 billion, which I can't imagine isn't an underestimate, because in order to get the true estimate, you would have to follow the offspring for a long period of time to see how they're functioning over the lifespan. So what's being done? There is a slow but sure paradigm shift from a model focused solely on the clinical outcomes of the pregnancy to inclusion of the mother's mental health. There are no current U.S. federal policies that I know of, but at least 12 states have taken some degree of action on maternal mental health. Now, that could be a committee to study it, a commitment to awareness and education. A handful have also recommended and enacted universal screening, which is in line with what ACOG and the American Academy of Pediatrics recommend. ACOG currently recommends full assessment of mood and emotional well-being, including screening for postpartum depression and anxiety with a validated instrument, that's an important piece of it, during the postpartum visit. AAP recommends PPD screening at the 1, 2, 4, and 6-month well-child visit. U.S. Preventative Services and Task Force and the APA are also on board, so there is a consensus around this issue. A former ACOG president said, because fewer than 20% of women in whom perinatal depression is diagnosed self-report their symptoms, routine screening by physicians is important to ensuring appropriate follow-up and treatment. So basically, these women aren't talking. They are not going in and disclosing how shaky they actually feel. And the validated instrument is also really important because there's a lot of research confirming the fact that saying, how are you feeling, is not the same as administering the Edinburgh Postnatal Depression Scale. It does not pick up or detect women that are depressed at the same rate. What about these recommendations? Are they being adhered to? Screening rates are inconsistent and low. You can't, canvass the literature and pinpoint, 33% of all pediatricians are screening. The data is inconsistent, it's patchy. We're working on that at Georgia, we're working on it at Mercer through their community preceptor network. But right now it's hard to tell. Anecdotally, I'm thinking probably 33%, varies. Nowhere near the majority of clinicians are screening. And there are reasons for that. There are plenty of barriers to screening. When you talk to physicians and when you look in the literature, you will repeatedly hear, I was not trained for this. An OB said to me, I was trained as a surgeon, and I see these women, and the only thing I feel capable or sure about prescribing is Zoloft. So I really want to help, and I really want to feel competent in this area, but I don't know the pharmacology. The other thing that can trip you up is establishing a protocol for screen positive women. So when you get somebody that screens positive, what do you do with her? Because screening is not as helpful if you don't have a treatment protocol in place. That's even more difficult in areas where there's a lack of mental health infrastructure, right? There aren't community resources, you don't have a psychiatrist in the area. So a lot of this work lands in the lap of OBs and family physicians and pediatricians who are not specifically trained for it. Again, another thing that's brought up over and over again is the pharmacology is complicated because you have to consider the impact on the fetus and then the impact of the transmission through breast milk. So it's a little more complicated and nuanced, and it requires additional training. The other thing that I hear brought up is from the pediatrician side, which is also reasonable, is I don't have access to the mother's medical records. She's not my patient. I was trained that the child is my patient. We've also heard, if I bring up mental health, there's such a stigma that it's going to damage my relationship with the patient and the whole family. But we have found that when you talk to practices that are screening, they will say it is of great value, it's improved their practice, and that the family is appreciative, that they have more robust care. I mentioned the guy who told me about Zoloft. I've challenged a little bit my own OB and said, well, for OCD and during pregnancy or even afterwards, what about Paxil? And he said, no, we don't prescribe Paxil. And I said, but why? And he couldn't, it's not his fault, but he couldn't really explain why. And there isn't a complete consensus on, Paxil being problematic. The data is pretty shaky. But if you understand that, you're making more informed decisions. A pediatrician said, I'll have a mom in front of me and I can see something's wrong and I want to ask, but I'm afraid she'll actually tell me. So then what do I do with her? If she indicates there's a problem, I've got a problem, right? Ethical obligation to treat, and I've got this person in front of me that I don't know exactly how to treat because I wasn't trained for it. So ACOG is moving, I think this is a really positive development towards something called recognizing the fourth trimester. And that's based on the fact that postpartum care should become an ongoing process rather than a single encounter. The way it's been handled is the 6-week follow-up visit, right? That's the standard. Even I thought when I had kids, I thought, man, there's a lot involved in this. I had a C-section both times, and I ended up with bilateral cataracts, which was very odd. But I thought, I'm getting to be seen how many times for these cataracts, multiple times after the surgery, and I got seen once after having major abdominal surgery and trying to breastfeed a child. So there's a disconnect there. And so I like that we're starting to address it. What that fourth trimester means is more ongoing and consistent contact with women starting at 3 weeks postpartum, leading up to a comprehensive postpartum visit between 4 and 12 weeks postpartum, which includes a full assessment of mood and mental health. So again, this work is not going anywhere. Especially in rural areas or underserved areas, this is going to land in the OB's lap. With more, more contact with the woman, it's going to come up more often. So if I had to recommend how to solve this problem, I identify 3 key areas. We need to train practicing clinicians who work with new mothers. The good news is these training modules already exist. They're not cost prohibitive. I've attended a training myself with many members from the Department of Public Health. We need to embed within medical schools, DO schools, nursing schools, we need to embed PMATS focused curriculum at the medical school ground roots level of training. I've already had some discussions with our dean about how we might do that in the 4th year. Again, we could make it an elective, strongly recommended elective for anyone interested in going into family practice, OB, peds, and psychiatry. Totally doable. I mean, we're recommending that you do the work. Let's empower the physicians to do the work in a way that makes them proud. What I think this will lead to is a more, highly trained workforce is increased screening rates for PMADs across the state. Ideally, would want to screen for depression, anxiety, and maternal functioning. And again, I just want to highlight, I think this win is within reach. And I say that because we have passionate providers who want to provide robust care to their patients. They see women that are struggling and they want to help. So the will is there for the most part. We already have validated screening tools and multiple depression screening tools. The one that's the most famous is the Edinburgh Postnatal Depression Scale. It's quick, easy to fill out, takes a couple minutes. We have the functioning measure. We also have a Georgia chapter. It's about 2 years old of Postpartum Support International. And what they do is they teach the pharmacology around childbearing. And they also provide a ton of resources. Some are online for dads, for mothers that have babies in the NICU. They're an incredible resource if you don't have a psychiatrist in your hometown. So I guess what, my point is, the good news is here is all the pieces are in place. We just need the will. We have the scientists, we have the tools, and I would personally love when I go and I, do international talks and national talks to be able to say that Georgia has an exquisitely prepared physician workforce to execute these evidence-based recommendations. Thank you.
Thank you very much. Representative Silcox.
Thank you, Madam Chair, and thank you for coming today. I really appreciate it. I was just curious, in your studies and what you know, what percentage of the maternal mortality deaths are due to the mental
Yeah, that's a question I am looking for an answer to. I think it depends on, we were just discussing this before my talk, how things are coded. I mean, it's a really complicated question.
Right.
I think suicide is probably more of a no-brainer.
Okay.
But my question is if someone receives a diagnosis of postpartum depression, how are those things documented and classified? So
Right.
it's not an, I've asked that question myself because that's the ultimate goal, right? Is to not be, at the bottom of the barrel in terms of mortality and morbidity.
Do we know at least the suicide rate?
I don't.
You don't?
I don't
Okay.
know the suicide.
Okay.
I especially don't know it in Georgia.
Okay, thank you.
Okay, thank you. Representative Hughley? Oh, sorry.
Thank you, Madam Chair. And thank you for your presentation. You mentioned about when you were talking about the effect on children, and you said that it had a greater effect on boys than girls. Would you speak more to that?
Yeah, what I know is with fetal, I don't actually do fetal programming research, but what the literature indicates at this point is that maternal mood, basically the intrauterine environment has an impact on the developing fetus, and the mother's maternal mental health has an impact on that environment. I don't know if they know why boys are disproportionately affected. It's a relatively new area of research too.
Is that it? Okay, Representative Stovall.
Thank you, Madam Chair, and thank you for the presentation. The question I have, with the doctors having now to the recommendation about doing a full assessment, how would that affect the amount of time, or how would they readjust their scheduled time that they already have with each one of the mothers that they are actually seeing?
Yeah, I think that's probably a good, so I'm not a physician, I'm a epidemiologist. I work with a lot of physicians, so that they would probably be better equipped to answer that question. It's definitely going to be some work. It's a different framework, the time points are different, and there's more contact. And if you look, there's a list on the memo from ACOG, and it's pretty comprehensive what they're asking for at that either 4 to 12 week comprehensive visit, and then a transition to well woman care. And what they're also recommending is individualized care if you have other risk factors. So certainly for people that are high risk OB patients, they should get more care. That's what it kind of indicates, that individualized plan within, but contact by 3 weeks, and then individualized care, and then between 4 and 12 weeks, a comprehensive visit. So will it have an impact? Absolutely. I think it'll take a while to get the kinks out, and not everybody will comply right away.
Representative Newton.
Hey, thank you again for your work. I know this has been years of work going into this, and I do, as a physician, I do appreciate the fact that you've made an easy to administer test, and from a brief look at it, I think it looks like something that staff can do as part of the visit, not necessarily the face-to-face time. How comfortable are you? I think one of your references talked about what if I find out it's positive? Now what do? I can't just write a prescription for it, which is the easy answer. This is going to involve a referral. Are there telemedicine resources for this? I was thinking about the fact that the last thing this woman needs is another appointment on her schedule to have to go to, or miss work, or arrange a caregiver. I was wondering, have you seen any, once again, if you do the screening and you find out either they're functioning or their depression, one or the other, or both, are off, I know the offices are going to want to know, well, now what? Now I've got a positive result.
Right.
Have you heard anything about telehealth in this?
So,
it seems ideally suited.
I have not directly worked on anything with telehealth in this particular area, but I'm sure that's someone somewhere is already doing it. Is it widespread? No. And that is what you describe as actually the bottleneck. That's where the problem is what do I do with her? So screening, I would argue that screening, even if you don't have a perfect answer to what do I do with her, you might recommend she called Postpartum Support International,
Right.
But it might not be ideal. What I would say is it beats a blank. It puts the mother's need, like that woman who said to me, nobody's ever asked about me. It's like my colleague refers to it as it's a piece of candy, and the baby's in the wrapper and the mom's the wrapper, and then when the candy comes out, the wrapper gets thrown away. So that sounds extreme, but we have definitely had more of a clinical focus on the clinical outcomes of the pregnancy than the mom's mental health. But you're right. I mean, and I see it in my own OB office. You're backed up. You have a full waiting room. You do the assessment. What do you do if you don't have an MFT or a social worker that you can refer them to? It can be problematic.
Can I ask one follow-up? Yeah. What is the most, you get that first visit, and that's the visit you're guaranteed. You mentioned your 4-week or whatever, 6-week visit. I know we've discussed the fact that some insurance plans kind of cut off after 42 days, and we're looking at options on that. How much of this shows up in the first, say, 6 weeks?
Yeah, that's another problem. Sometimes, with the way in practical application, physicians that I know of and what it says in the literature define postpartum depression as anywhere in that 12 months. That's
Right.
not what how the DSM classifies it, unless there's been a change and I haven't paid attention. But you're right. I mean, the way it stands now, the 6-week visit alone, it's just not even equipped to pick up everybody. That's why the pediatricians are
That's a good
involved,
point.
because they've got that longitudinal piece where they see the family over the course of the whole postpartum year. But again, the challenge with them is the kid's my patient, not the mom. I don't have her medical records. But again, the good news is there are plenty of people, not the majority, that are doing this and doing it successfully. I had a friend in Pittsburgh who delivered. She was screened at all the well child visits that she was supposed to be screened at. So, the ideal is to have somebody in-house and, mental health help in-house. I've been told not going to happen. So then why don't we train the OBs? At least then they'll feel more comfortable with medication. What if somebody's complicated? What if they need to be on lithium or Paxil is their best option, but, Paxil's been a little bit maligned. So that's why I would argue that this problem isn't going away. It's going to land especially probably in rural areas and areas that are underserved. It's gonna land in the family practice, OB, and pediatrician's lab.
Thank you.
Okay, Representative Astration.
Thank you, Dr. Barkin, for your testimony today. I guess my question is about this training of the OBs. If it's not cost prohibitive, we already have the protocols available to utilize. What obstacles do you see, or how do you envision this being rolled out and implemented so that these doctors receive that training and it's of actual benefit?
Yeah. So they have several different modules. They do have an online training too. So that could be helpful.
So
we could, or, embed it you'd embed it for going forward, embed it in that fourth year or last year of nursing school or whatever. Anyone that's dealing with basically serving that population, then they're getting it at a baseline. If nothing else, they at least know where to look. They might not remember how does lithium play out during pregnancy, but they know where to look. The groundwork is there.
That makes total sense, and of course, probably as research continues, there'll be other advancements after medical school, but absolutely, I understand that. I guess I'm wondering, is cooperation with physicians groups maybe the starting point, or have you seen, you were mentioning Pennsylvania or other states maybe that have imposed regulation to help us see that this training is followed through? Just any insight that you have will be helpful.
So, ideally, everybody's screening. I'm not going to lie. That is the end goal for anybody that cares about perinatal mental health. In general, they want universal screening. I've been warned that there will be pushback from physician groups on that anytime you kind of try to impose it looks like imposing a regulation on their profession. So that is a stumbling block for sure. One thing that I've talked to our dean about is we have a community preceptor network where we have a relationship with doctors all over the state, letting me go and start the groundwork, talking to them about the training and see if we can, we're not going to reach this in a year, but, set goals where we can, the Department of Public Health in several different districts has sent nurses and physicians. So it is possible. And
Thank you.
PSI is really good about working with you.
Thank you.
Dr. Gray?
Thank you, Madam Chair.
Gray.
As a comment and a question, number one, comment would be that both as an obstetrician, gynecologist, and a pharmacist, I fully understand the mechanism of the medications. But I guess the challenge here is that, one, I agree with the idea of universal screening, but I don't think I would ask a psychiatrist to deliver a baby. And so that might sound crazy, but my point would be is that it is a specialty, and I think it does become very challenging and something that you don't do routinely day in and day out. While it's common, the problem may fall in that across a specialty, even a primary care specialty, if you will, the comfort level with this is going to be problematic no matter how it's rolled out. When you have a positive screen, what to do next, because that's just the nature of medicine. The question would be, we have a lot of patients, probably more often than not, patients enter into pregnancy with mental health disorder already. And it looks like that the application is in the postnatal period for postnatal depression. Do you advocate for screening up front, to be clear, and in the postnatal period. Obviously, having the issue be that we generally don't take patients off their medications in
Right.
pregnancy. Can you just talk about the application of a screening tool where it would be ideally suited or in multiple places in prenatal care?
Another good question. Some of it's going to depend on the group you're talking to, right? Pediatricians can't. I mean, they couldn't do it during pregnancy. It has to be in the postpartum. I think ACOG recommends once, I think during the perinatal period. I don't have a strong opinion on during pregnancy or not. Sorry, that's kind of a gray answer, but I don't have a good answer for that. Certainly the frequency of contact with OBs is greater during pregnancy than it is in the postpartum. So would it be feasible? Probably in a way more feasible during pregnancy. You've got that close monitoring and at intervals. I don't have a real strong, I work a lot more, to be honest, on the postpartum end than on the pregnancy end. I know about it, it's included, it's part of what I do, but I'm really focused on the postpartum because as a mother and talking to mothers, I know the role that mothers play in the family. And even with the best husband, on earth, and maybe this is, I don't want to say every single family is like this, the woman, and this is regardless of whether she's full-time employed or not, is the primary, like I said, the lioness of family health. So she's kind of, everybody's keying off the mother. And if the mother is not in good shape, that's going to impact the family unit. So that wasn't a direct answer to your question, but certainly from a standpoint of logistics, probably easier. Although ACOG is moving towards a different model now, the 4th trimester, which I think is fabulous. Some countries are better at this than we are. They really kind of ritualize and protect that postpartum period and look at it as a major life transition. You could have a difficult labor. C-sections aren't easy. It's a major life event, and it's not looked at that way. It's getting better, but it's not where it should be. I would still argue's not totally the right word, but what I would state is that it beats a blank, right? You're going to have some OBs. One of my close friends has cared about maternal mental health intensely. It's been an interest of hers since she was in medical school. So we started working together on research studies. She routinely screens for depression and functioning. I should ask her, well, what do you do? They might have a social worker in the hospital. I think she has told me that. So she's an advantage, right? But I would argue that no matter what, it beats a blank. And because I know it's feasible. I mean, this is feasible. I've attended training myself. I can't do anything clinically with it, but I can recommend. And I've seen, like I said, multiple members of the Department of Public Health attend. And that's a project in progress with PSI.
Is that it? Okay. I think one of the things missing is perhaps that the state has, through the Department of Mental Illness, Disabilities, and I hate, DBHD. They've renamed it, and I hate that. We have crisis intervention teams and a crisis line, and maybe we need to make our physicians more aware of it. I mean, I would think that in a perfect world, they would screen and they would be available to help with people at all levels of identifying need on the scale. But to me, one of the big advantages, since this is a maternal mortality, and some of the deaths are due to suicide and that we miss, that if it would pick out severe cases, at least, that need immediate intervention, that those would be the ones that the physician would want to find some means of helping. And I think that our state would be a resource for that with a crisis intervention. To find help for a person if there was no local psychiatrist or somebody to talk to. Thank you very much for your presentation. Thank you for coming from Macon, and we really appreciate it.
Thank you.
You're welcome. Dr. Goldsmith.
Good afternoon. Thank you, Madam Chair Cooper and members of the committee. I'm going to pull up our presentation real quick.
And I know y'all have got another meeting. I hope we've left you
Not a problem. Thank you. I appreciate that. This is an important conversation, though, and we're excited. So my name is Callerin Mackey, and I serve as Assistant Vice President of State Affairs for Emory University. I'm actually so excited to talk to you about this because I think it dovetails really nicely with the presentation that we just heard. In particular, Representative Newton, to your questions about telemedicine, that's exactly what we're going to be talking about this afternoon. With me is Dr. Toby Goldsmith, a distinguished psychiatrist who has served as the director of the Emory Women's Mental Health Program for over 5 years. She has also been a member of the MMRC since 2012. So Dr. Goldsmith and I are here to provide you with an overview of an innovative project on which Emory is proud to partner with the Department of Public Health and the Healthy Mothers, Healthy Babies Coalition. And so as many of you know, I think many of you are probably aware of this project, the department and Emory are working to establish a maternal mental health telepsychiatry line, and that is dedicated to increasing capacity in Georgia to screen, refer, and treat maternal depression and related behavioral disorders in rural and underserved areas of the state. Telepsychiatry lines have received national attention for increasing screening rates and access to treatment. Georgia is one of 13 states currently implementing this type of program. We are very grateful to the state legislature for your support of this project and for appropriating funding to the Department of Public Health for making this possible. So to walk you through the details of the project and where things stand right now, I'm going to turn it over to Dr. Goldsmith. Thank you.
Thank you, Callerin. Dr. Goldsmith, welcome, and thank you very much for taking your time to come.
Oh, my pleasure. So I just had the opportunity to meet Dr. Barkin today. You would not know that when you hear what I'm going to talk about. And I think a lot of your questions hopefully will be answered, or I will be able to ask them if you ask them again. So I have been doing what I am doing for 25 years. Ever since I left my residency, I took the initiative to get educated about maternal mental health. And I hope that there are more people who will do what I do, but I'm going to force it down people's throats, whether they like it or not, and they're going to learn.
My kind of person.
Thank you. Okay. The goals of perinatal mental health are as follows. What we want to do is treat women who are currently pregnant or within 1 year of delivery. That makes sense. In addition, we want to start recognizing women who are at risk during pregnancy and for their postpartum period, because we might be able to do a lot if we can just identify them, start treating them, getting them the appropriate resources. So it looks pretty simple when you think about it. We have this partnership between Emory, the Department of Public Health, and the Healthy Mothers, Healthy Babies Coalition. And we have similar goals, and they are as follows. Again, we want to screen all pregnant and postpartum women for psychiatric issues. Now, someone had asked earlier about using the tool during pregnancy. It is recommended that we screen at least twice. And so it's recommended at their first visit for the pregnancy, they get screened using something like the Edinburgh Depression Scale. And then again, when the woman comes in, probably for her gestational diabetes screen, she should get it again. And let's see if there's a difference.
And that's when? What?
About 28 weeks. So we'll see women, who are already depressed, if you see them at that first, and maybe they've never had treatment, or people whose depression may have developed during the course of the pregnancy. Obviously, we're going to treat the vulnerable mothers, and we can talk about that further. Educating the medical community, as well as others, to recognize the signs and the symptoms of psychiatric illness among women. We want to decrease stigma. We want to make it easy for women to ask for help. We don't necessarily always want to have to go to them. It'd be nice if they would come to us. We want to provide resources to both clinicians and the moms. We want to make them easy to find. We'd like consistency across the state. Right now, if you are a pregnant woman and you live in Atlanta, there are a handful of psychiatrists who are very comfortable treating you. If you move out an hour away, there's no one. And we want to encourage more psychiatrists to specialize in women's health. But in addition, and this was brought up, I would like to get primary care providers, internists, family practitioners, OBs, not necessarily pediatricians, because that's a whole other issue, but to get them comfortable treating these patients. I'm not expecting them to do what I do, but they should be able to start a woman on some basic medication. The fourth trimester, I think you've heard that term before. For the most part, once a woman delivers, all she hears about and all she's questioned about is, how's the baby doing? And so, is the baby developing well? Or is you feeding the child easily? And those are the only things she hears. If we're lucky, someone's going to talk to her about how she's recovering. Is her C-section scar getting better? Is she having any issues down below that need to be addressed? As well as talking to her again about contraception and birth spacing. But we want to add things to that period of time, those 3-4 months after a woman delivers, that will allow us to treat the mother. We want to talk to them about their mood and their emotional well-being. We want to talk to her about sleep and fatigue, let her know what's normal, what's not normal. And we also want to talk to them about medication and substance abuse. Overall, our plan is simple. It's to screen women. We are going to provide practices throughout the state of Georgia with screening tools. I hadn't seen Dr. Barkin's tool until last week. I'm really interested in potentially using it, in addition to the Edinburgh. But again, that's only for postpartum situations. We are going to treat them. We are going to have a telephone line that people will be able to call up. Initially, as we are developing, it's primarily going to be a consultation line, doctor to doctor, where Dr. Smith can call, ask me questions about that individual that they're seeing.
That's great.
And say, what do I do? And based on that, we'll go from there. In the future, as we grow, what we would like to do is have telehealth where they can have a place where the woman's sitting in their office and I'm sitting in my office in Atlanta, and I can talk to that woman and she can become my patient for up to a year postpartum, which is exciting to think about. We want to offer support. We want to offer support not only to the patient, but also to the physician, because I know that physicians do develop a fair amount of anxiety about treating these special people. And then teaching. My goal is to teach as many people who will listen. You had asked earlier about how can we get these OBGYNs to actually get the education. One of my ideas is to do lunchtime conferences by telemedicine or whatever. It's outside my purview. But for me to teach, for my colleagues to teach, OBs, family medicine, et cetera, and then offer a half credit of CME for 30 minutes. Free CME, doctors will eat it up. And I think it will give us that opportunity. We can further the education. It was a blessing, but last week there was just a release of an entire curriculum of women's mental health education that is free and offered throughout the country. We will be able to use that in every medical school, in every residency. I think we can make an opportunity that we have the different educators, or even myself and my colleagues, to teach at the other medical schools, to teach in the departments of psychiatry, whether virtually or in person. I'm really excited. We have just hired a new woman who is joining us from MCG. Yes, got it. Okay. And she's an OB who's also a psychiatrist. But the two of us will be able to do such education. I want to teach anyone who's going to listen. And I think that will make a huge difference. And a big part of the education is simply the comfort and the recognition, knowing when to be scared and when not to be. Most of the time, thank goodness, we don't have to be scared. But physicians, we're a fearful bunch. And we just want to make them more comfortable. So I think that was my last, yes.
Okay,
Thank you, and
thank
I'd
you.
love to take questions.
Well, I have one to start with. And I think we have somebody talking about us, and then I know that there's a group down in the Albany area doing group sessions when pregnant ladies come in, and they sort of have grouped them together, and they talk about all sorts of things and have group education and so forth. It seems like to me that this would also work if you evaluate these people and don't have severe mental illness issues, but just are overwhelmed by the responsibility of the family and all, and are lower on a depression scale, that perhaps one way to reach a lot of these women would be in the formation of a group type settings that might be fostered by the group they got together with while they were pregnant, and
Which
the
is-
sharing that they're going on, that might be a really good way to handle it.
I agree. I know they do that, I believe, at Northside Hospital. They have cohorts based on when the women deliver, and that would be a possibility as well. You need people to lead the groups. There will be a need to educate people on how to lead a group. There are groups as well online, so that might be an option as well, as to lead these women to where they can find other people who understand.
Okay, you have questions? Registration.
Thank you, Madam Chair. Thank you, Doctor. I really appreciate your testimony. Your second goal is with respect to prevention amongst mothers who have a history of psychiatric illness. I'm wondering of mothers, did I get that right?
It's more recognition of women who are
I'm
at
sorry.
risk.
Okay. And so I guess my question is, of mothers who are diagnosed with anxiety or depression after birth, do you have studies about what the percentage is of those with an existing history of psychiatric illness?
In the community, again, it's anywhere between, well, we'll give the number of 1 in 7 women are at risk. Once a woman has developed postpartum depression, postpartum anxiety, her risk is going to be 1 in 5 at least in the future.
I'm sorry. I'm more looking retrospectively. So if a mother has depression or anxiety, was there a signal factor because of previous treatment that maybe would be indicative? Okay, and that
Overwhelmingly.
I'm asking all this because would maybe focus on that population have a greater impact as well with postpartum depression and anxiety?
It would, but most of the women who come to me with postpartum depression, postpartum anxiety, who have a previous psychiatric history, have never been treated.
Okay. Thank you.
Okay, Representative Silcox.
Thank you, Dr. Goldstein. I really appreciate your presentation and your focus on women's health. Just was going to mention Dr. Ann Patterson. She's a specialist in Sandy Springs. She works with Northside, and her business strictly is women's telehealth. And she works with high-risk patients primarily that are either having babies later or because the patient's already got diabetes or other complications. She takes care of those folks, and so she is doing women's telehealth now, and we'd be glad to share.
Are you introducing Dr. Patterson? She's here in the next one
She's
on the
here.
program.
She's here. How awesome! Please get connected with Dr. Patterson because she wants to do what she wants to help with what you're doing,
That's
and
great.
she would be a great help. And I'm glad you're here. I couldn't see you behind the column.
I'm sorry, Deborah, but I had to get you.
No, I didn't know she was here.
Hi, Jean. Which one? Dr. Ellis.
quite a while. I'm very supportive of your work and glad to see that it's rolling forward. I just have to say, I guess because of the population I see at grade E that's very high risk for depression and so forth, our residents screen at almost every visit because, I mean, some patients you don't see, you know, they don't keep appointments
Sure.
and it's a long time between their visits. And even patients who are coming in like they're supposed to, initially it's every 4 weeks. So I was just asking Dr. Ray if they're doing that, and probably not as often as we do, but, and I just finished clinic this morning, and every patient that we saw in my high-risk clinic, it's not a detailed survey, but it's just a quick, how are you feeling today? You have any symptoms of feeling blue, any feelings of hurting yourself, hurting anybody else, and, you know, just sort of a very cursory review, as well as for domestic violence. And our residents ask about seatbelt use. So I think incorporating, and it takes, 2 minutes when you walk in the room while you're pulling up the computer and things like that. So it's really not that difficult to do. And I think it may be easier to start with residents or even medical students, because we send medical students in sometimes to do a lot of the preliminary work like this. Old folks like me are going to say, "Ugh, I got another lunchtime conference to go to,"
But we'll
So-
give you CME, Jane.
I get that from ACOG. So anyway, I get your point. But I think maybe the earlier we start training future physicians and current physicians that are going to be out in practice to start looking for these things. And I'm very fortunate that I have an OB psychiatrist at Grady. So, I count my blessings every day when I find somebody who's going to need medication and I can refer to Dr. Herbert. So most people don't have that luxury. So I really appreciate your work.
Thank you. Okay. Representative Newton.
Thank you again for your work. You mentioned that about the referrals that you get, obviously postpartum, I guess most of the time, maybe some of both. And you mentioned the high risk that we're already on the lookout for ones if they've, especially if they had a diagnosed preterm or pre-delivery. How far out is it when you first see them? Like when somebody has done their screening, somebody has screened in, is that typically a week or two later, or where is it being picked up? I'm wondering when you first, I know it's a subset that would actually get referred to you, but.
It's a wide range. There are women
Six
who.
months?
I have seen women, and I continue to see women who just got diagnosed with their pregnancy, and their doctor picked up on something, or they're on a medication, and so they're referred to me for
That's, okay,
my
pre-delivery,
opinion.
yeah.
Correct.
Pre-delivery.
And then I will see women who someone picked up on something while she was still in the hospital at the delivery. I get a lot of the referrals from the NICU, from neonatal intensive care units, when they're trying to help their moms there. Then I see women up to 12 months postpartum. But
new
the
patient,
majority of them, probably the first 2 to 3 months.
Okay, thank you.
Okay, I have a question. Who's paying for this?
To see my patients? For it to see me?
The program?
You are? Or you will be? Yes. Yeah. It's a state-funded program. And thank
Okay.
you, thank you, thank you.
Well, you're welcome. I mean, is it on a temporary basis or?
For right now,
Not for right now it is? Wait, I just want,
Yeah, sorry, it was a line item included in the last state budget.
okay, so it
In
would
the
have to be
2910
it would
session.
have to be refunded.
Correct.
Okay, and
Oh,
it's
no.
state,
Sorry. No, I believe it's a line item, so it would be recurring.
okay, unless it's taken, okay, great.
Yes.
Okay, Dr. Ray, just want to make sure it was being paid for and available to everybody.
Yeah.
That it would meet, not just, if we have somebody that couldn't pay for it, that it's available to them.
Yeah.
That's exactly what it is. Right now, if you have good insurance, you can see me within a week or two. But if you don't, people don't have access, unfortunately. But that's my practice at Emory versus this program with DPH and Healthy Mothers, Healthy Babies.
Okay. Okay. Dr. Ray.
Thank you, Madam Chair. I share Dr. Ellis's comments. I've appreciated working with you on the MMRC and always appreciate your commentary. It's very valuable to the state. First question is that clearly the need for a program like this is because of workforce shortage and the difficulties that there are as it relates to getting mental health for our patients. Is there some? Can you comment on the directionality of this? Is there some? Do you have any comment about how the workforce is going for psychiatry and mental health services specifically for women, and how it might relate to maternal mortality?
I really can't. I can guess. There are more and more psychiatrists being trained. However, and I believe that more individuals are choosing to specialize in perinatal mental health, because as more of us speak up and let it be known, and hospitals supporting the education of such programs, there are more of us, but there's never enough.
The program itself is extremely interesting. I think that, my comment earlier, I'm forced to do mental health nearly every day in my own office. And while I feel fairly comfortable at this point in my career doing so, it's really about the scratching the surface, if you will, prescribing medication for perinatal depression when you talk about an ever-widening scope of illness, because mental health disorders are broad. The idea that I could call and have a doctor-to-doctor line is great. One, do you have an anticipated volume by which you would expect right off? And also, what is this? Will this have a widening scope? I mean, I fear that it will extend beyond perinatal mood disorders and anxiety, specifically to like addiction medicine and things like this, if it's not uniquely defined.
I think it's going to. And as a result, I'm trying to educate myself on that area specifically, because that affects so many of our mothers, especially in the rural areas. We're going to have to grow if the state wants to address this population. What was your first part of your question again?
What is your anticipated volume?
We spoke with the group from Massachusetts a few weeks back, and I believe they said they saw about dealt with about 120 per month. And I think ultimately we're going to probably double that. I think if we get the word out, and I think we have the resources to educate individuals about us, we're going to be hopping.
One last comment, if you don't mind. I just, for the sake of argument, we're here and we talk about maternal mortality. While you're on the Maternal Mortality Review Committee, and you know that we see suicides, right. We see other reasons for a maternal death, though. It's not just simply about suicide, and I think it's important to realize that for every patient we see that is a maternal death, there are likely, potentially hundreds of women who are affected by this, and so I really appreciate the program.
Thank you.
Are you talking about what we would call near misses? That maybe they get close to killing themselves or are so depressed that they would like to do it. I think you're right, Dr. Ray, in the depression.
Overall for maternal mortality, but large numbers of mental health disorders. So,
just
during
based on our
pregnancy,
inpatients,
right.
I could say that.
So I think this is an excellent thing. Representative Stovall.
Thank you, Madam Chair. Could you go back over, I think Representative Estration was asking about the risk, and you said 1 in 7, and then you said 1 in 5, but I missed what you were talking about. I wrote down something
In
about
general,
the risk.
your first baby, the risk is about 1 in 7, assuming you have no prior history. But once you've had postpartum depression, postpartum anxiety, your risk goes up with your next pregnancy to at least 1 in 5. I think it's higher, but that's what the statistics say.
So, thank you. Okay, Representative Estration.
Thank you, Madam Chair. Just follow up, I appreciate it real quick. So just along those lines then, if in the original screening that we've already spoken about, the need for that, it's diagnosed that there was a psychiatric illness history, then particularly focusing on that population of mothers would potentially identify other mothers who might have a higher likelihood to suffer depression, anxiety. Is that fair?
Correct.
All right. Thank you.
Okay. Well, thank you so much for coming, Dr. Goldsmith, and for what you're doing. There's so much to state government, and I think sometimes, and as we started this, there was a feeling that the state was not doing anything to work on our mortality rate. And I think one thing we are hearing is that we are doing a lot to work for all the women, regardless, from age, race, or whatever. And that pleases me that we are looking at this. It's just from the bundles in the hospital for hemorrhage to other areas. So thank you for this program, and thank you for hopefully getting that expanded doctor-to-doctor phone line available. And so doctors out in the hinterlands could feel like they have a reference and help when they identify mothers and postpartum or whenever with mental illness. I appreciate your work. Thank you.
Thank you.
All right. Dr. Patterson, you're up. And thank you for still being willing to come when one of the chairmen has not written a thank you note for a very informative and delightful lunch I had with you. Me. I don't think she heard me. I think I still have to apologize again. Huh? Huh?
So let's see if it, well, we see if it opens it. That's my
she's
issue.
great.
If not, I have my own computer and it will open it there.
Other side. Other side.
It's on both sides.
We hope it's going to open.
Thank you.
Well, I'll try. Well, we can control alt delete it, that's for sure.
I'm not crazy. There it is. There we go.
Yeah. So the big deal is if it will open this one.
It's sensitive.
Let me sign. Can I sign in? It should then.
No one can see this.
Okay, so it will open it, thank
I think
goodness.
so. Yeah.
All right.
Yeah.
So, yeah, I think so.
Just click right there. Oh, no, one more. One more. This way. Yep.
There we go.
There we
Okay. Is that up for you all? Okay. So I'm Ann Patterson. My business partner, Tanya Mack, has joined me, and we do something called Women's Telehealth. We started the company about 8.5 years ago. We have worked together, and the team that's with me have a lot of years together. We have seen over 31,000 maternal fetal medicine visits in the past 8.5 years. All by telehealth. We don't do any physical evaluations in office. We are located in Sandy Springs. Representative Silcox has actually visited us and seen some of the consults with us. We are licensed in multiple states. You have to be licensed in the state where you see patients. And we do MFM consults, we do teleradiology, and we can do long-distance learning because obviously we have to have sonographers who are MFM sonographers that can do the right type of scan, and we can do this real-time with them. We are in private practices, we are in governments, and we are in the health department in Albany, and we'll go through that here in just a second. And we are in hospitals. We have a specific EMR that has telemedicine embedded in it, but we also have a PACS system with reporting capabilities so that whenever we see a patient and provide an ultrasound or a consult, it can go seamlessly back into anybody's medical record. It's done electronically. I hit a button.
Wow.
That's the amount. It took a little developing to get there, but it's very slick. To that end, we want to show you some of the other things that we have been able to do. And one of our real things that we're really proud about and want to share with you today is what we have done with the health department in Albany. We feel like it's a really big success story. We started there roughly 7 years ago. We joined Centering Pregnancy and the DPH office there with telemedicine. We're going to show you a video in a minute about that. And over that period of time, we've seen a lot of patients. And there's a published study that you'll see the slide of in a minute. But we chose Albany for multiple reasons. So in the state of Georgia, we have a high preterm birth rate, as you are well aware. It's about 13% roughly. The national average is 9.9%. Well, Albany was particularly bad. They were 18% in the African American population and 16% in the Hispanic population. So that was one of the driving forces to join that group. And with the work there, within 18 months, we were able to reduce the prenatal birth rate from 18 to 8% in the African American population and to 6% in the Hispanic population, and it's even lower today. And so we have done really well with this. We also follow the mothers for a year, and we have had one maternal death that happened 3 months ago, and she was killed in a motor vehicle accident, obviously something we cannot control. But we have had really good success with all of this. So I'm going to show a video, or attempt to here. I guess we'll get out of this. So let me do. Nope. So let me get this video to go here. Now this was filmed several years ago in the Senate, and you're going to see a live presentation at, is it not showing up there? This is a live presentation from Albany, and
I don't know if I can answer this, so hold on. Shoot. It's not going to show.
Okay.
I don't know how to make it.
How to project it.
Let me see if I have one more setting.
Okay. So anyway, it was a live presentation made in the Senate here with a patient being scanned live in Albany, and Dr. Jackie Grant was there with the patient. And it was, I think at first everybody just kind of thought it was a video, but then all of a sudden at the end, the patient waves at the audience, and although I'm telling them she can see what's going on here. I think people realized this was live, but we also have the ultrasound scan. I'm sorry it's not. Okay, so anyway, we will eventually show you this, I hope, because it's only 2 minutes, but I think it really captures the fact that you can see a scan live, you can see the patient live, you have a great interaction, and obviously address any kind of problem that the patient has. Telemedicine can address anything that's not hands-on. Obviously, you can't do an interfetal transfusion, you can't do an amniocentesis, but you can do almost any other kind of visit. And you always have a telehealth presenter there with the patient, because sometimes it is bad news. Sometimes you really do have to say, you know, your baby has such and such. This is what we need to do. Or, I've been faced with, this is a patient that you've lost your baby. And that's sad, but you have to be able to deal with that through telemedicine, and we can and have. I think one of the greatest compliments I've had in that instance was I had a patient by telemedicine who said to me, can you ask the nurse to leave? I really have to talk to you privately. And I said, certainly. So the lady stepped out, and she said, I'm really afraid I have HIV, and you're the only person I feel I can trust. So obviously, I was able to connect with her by telemedicine. And I tell you this because it's important to realize you can connect just like you were standing in the room with the patient. So let's put the video on hold. We'll go back to the slides, and hopefully you'll get to see it.
Someone's coming.
Someone's coming. Okay, well, hopefully at the end we'll get there. So, why is it not coming back up? Here we go.
Stay down here with us.
There we go. Okay. Sorry, we're not trying to have more exercise here. So this is the study that I talked about where we reduced the preterm birth rate from 18 to 8 and 16 to 6%. It's a published article in the American Telemedicine Association. And we are certainly very proud of it. It was co-written with DPH and Albany. And the other thing about this program is it's easy to replicate. Obviously, we have been in one health district. We have been enormously successful. To put this program in place, the state actually has already have some of the moving parts. It's definitely less than $50,000 per site. There are monthly maintenance fees. You have to have an adequate ultrasound machine, usually leased. You have telemedicine connectivity, which the state already has. You have to have a PAC system, and you have to have staff to be there with the patient. And the expense, roughly, we figure, is about $50,000 a year. Now, the state can actually bill for all these visits. They can bill Medicaid. And we made an estimate of what the state gets in Albany is roughly $4,000 to $5,000 a month. So it's pretty much a wash. The state may make a little bit. The savings are enormous. By cutting the preterm birth rate, we were able to save an estimate of the number of babies that potentially would have delivered that didn't deliver early, an estimate of over $5 million to the state. And that is huge. If this is scaled up, oh, you ready? Yep.
Do you have a video you need to show?
Absolutely.
Sure.
That's fine, no problem. So let's, if we can get out of here. I'll go that way and down. So here is my video. If you can get it to project.
Sure thing. What we'll do is we'll just do this. Wait for it. There we go.
Okay, just hit play.
Wait, hold on. Tara, will you hit computer audio on that panel? Computer audio should be up towards the top. Now we should be able to play it.
Nurse practitioner, Elena Milling, who has been doing some very extraordinary things in their local community to try to help pregnancies be sustained and keep babies out of NICU. And that is very, very important. In fact, they are leading the way in Georgia in what they are doing in centering pregnancy. To that end, we have joined with them, my company, Women's Telehealth, to provide maternal fetal medicine care or high-risk care in a local community many miles from Atlanta. My office is here. As you can see on the screen, they are actually scanning a patient who has graciously agreed to let you all see her baby. And we can see, you can see the heart beating there. And we can assess the baby in real time, just like you're seeing here on the screen. We can talk to the patient, who you can see in the corner of your screen, and they're seeing us. They're seeing exactly what we are doing here on their screen there, and it's interactive. We can tell them what's wrong, what's not wrong. We can give them encouragement. We can give them feedback. We can arrange for them to have whatever follow-up they need. And this is a wonderful outreach that is provided by the use of telemedicine, the Georgia Partnership with Telehealth, and maternal fetal medicine in the health department, which is a first. We have not ever done this anywhere in the country before. Georgia, once again, is leading the way. Dr. Grant?
Hi, good morning. It's such an honor and a privilege to be able to show what we're doing here. We are very thankful for the work that Dr. Patterson, who actually trained me at Emory University, so it's just wonderful to be partnering with her in this capacity. But we are doing some really cutting-edge stuff here. The first centering program in the nation to employ telemedicine. And we've been, I think our patients really enjoy it, they benefit from it, and we are having just outstanding outcomes with it.
Very much.
And we have the mom and her husband here who have agreed to do this.
All right. Well, they look very excited. All right. Well, thank y'all very, very much. very best to you both, along with that pretty little baby boy that will be here shortly. Thank you. God bless.
I wanted you to see that because I wanted you to see what we really have been able to do, and that's, you really never really appreciate it, I don't think, unless you do it, or unless you see it live. I think it just brings the point home of the capabilities that you have. So let's see if we can get back to this.
Sure.
Yeah. I hit
You
the
know
wrong
what slide
button.
we're on? No, it's okay.
Yeah, there we go. There we go.
This slide right here?
Right here. There we go. Okay, got it. So obviously, you have a picture of our office. We are connected with clinics and hospitals wherever, and you'll see one of our little outcomes over here. She was a severely growth retarded baby that we were able to help get to close to term, and she's done really, really well, even though she still has oxygen. Not now, but as a baby she did. She's now 6 years old and doing quite well. So resources and gaps. You all have medicine connectivity in every DPH district. We have a long-term relationship. We actually have a contract with the state and with the Albany Health District. So I think it's a long-term study that needs no other pilot. We've proven its success. The gaps that need to be filled if we expand this out will obviously be ultrasound equipment, trained technicians, a PAC system, which we have part of, and the training required for MFM sonographers, which we can help with, and a change in how OB is supervised. Now, why do I say that? So here is an issue that we run across. In the health departments, particularly in Albany, they've had an OB and then they've had a primary care physician, and those physicians can bill Medicaid for obstetric care. A pediatrician, internist cannot. So there's going to have to be a way to solve that problem if the health departments in different districts are going to do obstetrics. Now, there are different ways to do this, obviously, but that's something that's going to have to be addressed.
You're saying that in the health departments, some of the health directors that would normally bill would be a pediatrician.
And they can't bill Medicaid for obstetric
Okay,
care.
and they would be the supervising physician. That one public health physician in that area would be the one that would bill. Got it.
Now, there are different ways to answer that problem.
Well, we make exceptions on that we can do that. That's
okay. The other thing is,
no problem.
A physician can supervise 4 mid-levels. Now, if
Right.
you're doing telemedicine, you really should be able to have a lot more mid-levels than just 4 because it's not a brick-and-mortar office practice. It's a completely different animal, and that's another thing that would need to be addressed.
We have exceptions under public health. We can look at that.
All right. So those are some of the things. It's certainly scalable. I think you could bring up 3 to 4 sites a quarter. I think you could really put this into each health district. I think that you need a map to decide where are the most critical places and make some decisions about how you wanted to bring it up. But it certainly is something that could be done, and I think I can't foresee that it should be any less successful than we have been in Albany.
Okay. How do you get paid? I don't mean you, the company.
Well, we have done a lot of this gratis, to be honest with you, which is not the best way to do that. So we would have to be compensated if we rolled this out.
But, and so this first part that you're doing with Albany is gratis?
Well, a lot of it is. I mean,
Okay.
sometimes, not the visits. When they come into Albany for their OB visits, that's on a centering program, and that's through the health department. If we see the patients, if we can bill Medicaid, we do.
Okay.
A lot of the patients are private pay, and sometimes they can pay us $20, and sometimes they can't. So a lot of the patients, especially the Hispanic people that come from Ellington, we're not always paid.
Right. Okay.
The last slide is just, and on your last page are our contact information.
We have questions. I think it started. Do you have one? Okay, Representative
sir.
Newton.
Thank you so much for this. I think avoiding premature deliveries and just the difference it makes in all the maternal and mental health we talked about earlier, along with everything, is just amazing. I'm trying to understand, these are just people who are associated with the health department, or could it be an obstetrician in Waycross or Brunswick, or where are there some areas that have obstetricians but no MFM backup?
Lots of
whether
places.
whether ACA insurance, state health department, something else.
So there are actually 50 of us in the state. We're clustered mostly in cities.
Right.
So, patients often have to drive if they're going to see an MFM. That's why telemedicine for this is really nice. To have a place that's a venue where they can be seen. The health department is often a good place, I think, because patients can come there for their ultrasound or visit from different practices. That's certainly a feasibility. It's very neutral. And if that particular health district wants to have a program where they have a ongoing evaluation and pregnancy care for the patients like they do in Albany, that's certainly a possibility. Obviously, not every health district does that. And what happens with the patients, obviously, the 2 nurse practitioners I work with do not deliver, and at about 36 weeks, they have a relationship with several different practices, and the patients are referred out at 36 weeks to see that group and then do the delivery.
Okay. All right. Thank you.
Okay, Representative.
Thank you, Madam Chair, and thank you for your work in this area. With this, and are you the only company that does this, or?
Yes, ma'am.
Okay. So, if I remember correctly, this was like a group. The centering project is where the mothers to be were seen in groups. Is that
Yes.
right?
It is a type of group situation. So how this kind of works is they do sign up for centering. They come. They are in a group, and what we do voluntarily is we are there 4 times during the pregnancy. And so yes, I'm on a TV screen with them, and I get ask them very odd questions. But we talk about some very important things along the way. We talk about diabetes, hypertension, genetic testing, and preterm labor are the 4 topics we typically talk about at various times, at the appropriate times during gestation. And then the patients are comfortable, they've seen me before. If there is a problem or whatever, and that's part of the centering model, that you don't bring outsiders in, then they're comfortable seeing us, and that has worked really well.
And you said that you followed them for a period of time after delivery?
The centering project does. They follow them for 1 year, and that's how we know that the patient, that we know of, we only know of 1 maternal death, which was a couple of months ago.
And so this mental health that we've been talking about, is that incorporated into this model at all?
It is. Those questions are asked. The 2 nurses, and they are very enthusiastic about this, are Karen Baker and Valina Millings, and they said they would just love to share this with any health department that wanted to do this. They're very excited.
Thank you.
Dr. Ellis.
Madam Chair, thank you, Dr. Patterson. Dr. Patterson and I go way back. We went to Georgia Tech together many years ago, and I've actually visited her office a couple of years back. And I think when we were on Sea Island for a meeting, I was actually joined you, and you did a consult even remotely on your laptop, which I thought was very impressive. And I'm happy to say Dr. Jameson, who is our chair at Emory, and I are going out to see Dr. Patterson's office in December, I think, to look at your setup. Just a question for you. So if you suppose you see a patient via telemed that you think then needs a referral to a cardiologist or a rheumatologist or a pulmonologist, do you already have contacts in place that you can make those referrals, or how does that work? Does the primary OB make the referrals, or how is that handled?
I usually do, or there are actually 2 other doctors who work with me, but we try to know who is available in that area where we are. We are obviously in more than 1 state. And different places approach things differently. But say I have a patient there who definitely needs to be referred, and say she's a patient in South Carolina, I have no problem picking up the phone and calling MUSC and saying this is a situation I need to transfer this patient to you. I have never had someone say no. I've never, and I've done this a long time. So I think, you know, there are different places approach things differently and how they want to see the patient. For instance, near Northside, if you have a patient that has a baby with a kidney problem, they typically want to see the patient in consult beforehand, would like to see the baby 2 to 3 weeks after, so the baby, since labor and delivery is often dehydrating, they like to see what the kidneys look like 2 to 3 weeks out, unless there's a really significant problem. In Birmingham, totally different animal. They don't want to see the patient in consult. They don't want to have anything to do with it, and they want to see the baby immediately after delivery. So you have to kind of learn what your referral source is like or whatever, but, you know, it's something you can work through.
Representative Stovall.
Thank you, Madam Chair. You had mentioned earlier, and thank you for your presentation. You had mentioned earlier about the Hispanic mothers not being able to pay, and so I was trying to figure out what would have been preventing them from having Medicaid and them being a private pay.
Illegal.
Oh, okay.
I see a lot of illegal patients that are migrant and are farming workers, and a lot of times they have a hard time even getting from the place that they are down near Moultrie up to Albany. So that's why.
Okay, thank you.
So, well, I'm certainly glad that they found you in the telemedicine. Pardon? Right. Got it. Right. And so, I mean, because pregnancy is certainly something that we, no matter what, we need to make sure the babies get here and the mothers are taken care of. Representative Selcox.
Dr. Patterson, such a pleasure to see you. Thank you for coming, and thank you for your innovation in this area, because I really am convinced that so many medical issues that we have in the state can be solved with telemedicine, so I just applaud you for your efforts. But second, was going to ask, has there been any effort to work with the federally qualified health centers in addition to DPH to coordinate there as well for people that are legal but you know, can't pay full price?
Yes, we had a long-standing relationship with a clinic in Greensboro that unfortunately has had some issues, and they had a wonderful nurse practitioner, and I kept telling them, you know, she's just one, you're going to burn her out. She can't take phone calls 24/7, 365. It's just not possible, and they did. She left, and the program kind of fell apart because you really need to have someone who is overseeing a pregnancy program for us to be embedded there. And that was really sad because, as I'm sure all of you know, we have this giant gulf between where people can deliver, and they deliver in Athens, and they deliver in Milledgeville, and they deliver in Statesboro, and then it's Savannah and Augusta and Douglas, Georgia, and then you go north, it's Stevens County and Habersham, and you know, there's this wide gap of places where no one is. So to have a place in Greensboro, even though the deliveries were done in Athens, it was really helpful. So we'll see, but we are also actively talking to someone up in Hamilton County.
Great, and just as a follow-up to that, what are the biggest barriers to this? I know that, you know, that you had this video, for example, a number of years ago now. Why hasn't this taken off more? What are the barriers?
I wish I knew. I think it's wonderful.
Right. But I'm like, why hasn't this spread more statewide to more practices than yours?
You know, I think there are a lot of. I don't think it's suited to embed it in a practice where you're doing MFM in-house. I think telemedicine is its own animal, and you really have to be dedicated to do that, as to try to put it in and see someone in between seeing patients is very difficult, because the time frame of pulling patients in from different places is often a challenge. So I think that's one of the reasons that it's suited for someone that's doing it. Slower adoption. Yeah, I think people have been slow to adopt it. I think physicians are conservative. We've never done it that way. Why should we do it now? Hospitals are the same way. And you really, when you start a place, you have to almost have a champion. You have to have someone who's going to say, I'm going to see this and see it through, and get it done. And for instance, we went to a hospital in Alabama, and the CEO first said, "I'm never going to do this." And then he became our greatest cheerleader, and he has been absolutely amazing. And it has brought health care to an area of Alabama where they really never had this, and they've grown so much they're now going to build a children's hospital attached to their hospital. So, and we've been there a year. So it's made a huge difference.
Congratulations.
So it depends, but you really need somebody on the ground that is going to be your champion.
Thank you.
Okay, Dr. Patterson, I have one last question.
Okay.
And I'm going to forget what it was. Right. Okay. I've been asked to look at a proposed board rule, and it has to do. Shaking your head. You know what it is?
No.
About your partner's shaking her head. She does. That would say that for safety factors, physicians have to see the person first, in person. This one you're talking about? No.
But I can speak to that.
Okay. You want to?
So this was a big contention in telemedicine, especially those of you might remember in Texas, where there was a lot of litigation around, telehealth rules are made state by state in part. Texas actually had a law on the book for many years that said if your very first visit was to establish a doctor-patient relationship, then every visit thereafter could be by telehealth.
Right.
But you had to establish the relationship. It kind of defeated the purpose. You had people in Texas, from West Texas, that would never drive.
Right.
And I think Dr. Patterson's point today is you can establish a lot. There is a line in the sand. Not every visit is for telehealth is appropriate, but you can build relationships. You can diagnose, you can screen, you can treat, all by telehealth, not coming in person. They were litigated. Texas has released that now.
Okay.
So that rule does not exist. But again, we're state to state. We're blessed in Georgia. We don't have that rule here.
Yet.
Yet.
Okay, so, and I know the answer to this, but a rule like that would shut you down for the program you're doing in Albany and around
For the program in Albany, yes.
Yeah.
Okay. For other things, often an OB sees the patient first and then refers them to us. But if we have been able to be successful doing this in Albany with a physician overseeing it, and then they do, Dr. Ruiz is a primary care physician, he's the health director in Albany, and the nurses there are very liberal about contacting him for any problem. It would be detrimental to that program, and it would certainly be detrimental to rolling this out into any other area. When Georgia needs health care, Georgia needs obstetricians, Georgia needs obstetric care, you want to say, why do we want to make this harder?
Dr. Patterson, that's a question I'll be asking the board. I've already told the people that I will go with them to the board meeting. I understand about telemedicine and our need for it across our state. So
the other thing is, if that ever becomes an issue that you would like,
you want to go with me?
I'll be more than happy to make a presentation. Just let me know.
Okay, and I'll buy you lunch to pay you back for the one I never said thank you for. Thank you for taking me out.
You're welcome.
I enjoyed my visit with you. Thank you very much for coming and taking the time, to both of you, for that.
You're welcome. Thank you.
Mary Catherine Moffitt. And we are going to run a little later today, past 3 o'clock. I cannot tell you how many requests we have for people to come and talk. I think we could have 10 meetings. So just have to bear with me when we go a little later today. Oh, are y'all settling in? No, it's okay. Huh? It's fine. I'm just, all right. And
thank you, Madam Chairman.
Okay, if you'll introduce yourselves.
Yeah, we have Mike. Yep. And okay, great. My name is Mary Catherine Moffitt. I represent Nurse Family Partnership, and I appreciate the time to be able to address you, Madam Chairman and Mr. Chairman and the committee. I'll start, as you requested, to introduce my colleagues who are here, who could all speak more eloquently about this program and what it can do for Georgia moms, especially around morbidity and mortality.
Okay.
But we'll each take some time to share with you a little bit of our expert experience. So to my left is a Nurse Family Partnership nurse who represents families down in Warner Robins in the Houston County area. And to my immediate left is Ashanti Duncan, who's going to share her story with you after I share a few brief comments and overview about the program. My colleague Ashley Watson is going to run slides. I don't know where she went. But Ashley is also a Nurse Family Partnership graduate of the program and now works for the Nurse Family Partnership program at the National Service Office. Any of these women could speak to this program more eloquently than I, but I will do my best. So I appreciate your time to address the committee, and I appreciate the effort that the state has made in looking at solutions to reduce maternal mortality and morbidity for women in Georgia, particularly in the disparity between Black women and white women, and the risk of delivering a baby. I will tell you that I represent Nurse Family Partnership in 7 states around the Southeast, including but not limited to Georgia. So I want to bring you some perspective in how this can be a program that's part of your solution to this issue. I can share with you relatively that I serve on as a governor's appointee on a committee in Louisiana to address this same issue that the study committee is challenged to do, aptly named Healthy Mothers, Healthy Babies, similar to the coalition here. And also Nurse Family Partnership was recently scaled in 2 counties in Alabama, just across the state line from Columbus, Georgia, to address the state's highest infant mortality rates. And so as a evidence-based program, Nurse Family Partnership has been utilized in those specific capacities most recently. Let me tell you about the evidentiary foundations of the model. There are very few prevention programs that invest in what's the gold standard for research, which is a blind study or a randomized control trial. And so Nurse Family Partnership is founded on the idea of pairing bachelor's level nurses with first-time pregnant women early in pregnancy. And we've tested that with 3 different populations since the 1970s. And what I'd like to point out for you today is specifically the Memphis, Tennessee trial, which focused on mostly Black women who lived in urban neighborhoods with very limited resources and impacted adversely by extreme poverty. That trial is also the largest and the longest running trial that Nurse Family Partnership has invested in. In fact, yesterday specifically, an article was published nationally in the journal Pediatrics, highlighting 2 18-year long-term studies that simply address how are the women and their babies faring after being nurse home visited through the RCT starting in 1990. And we learned some really interesting facts that I wanted to be sure I added here. One is that the return on investment to the model was $17,300 per family over the course of 18 years. So return on investment net after the cost of the program was still $4,500 per family. And that was a really interesting finding. Further, it told us a few things about those families. Women who enrolled as pregnant women were more likely to be married or cohabitate with their partner. Their partners were more likely to stay employed for a longer time than their peers who were not nurse visited. That talks to us about relationship, supporting as the baby as parents, but also economic self-sufficiency, which is one of the domains of this program. And so looking at that in the long-term study was really compelling. What we learned also about the babies who were nurse home visited through this model when they became 18 is that they were more likely to graduate from high school, more likely to graduate from high school with honors, more likely to excel in subjects of math and science. And also they were more apt to be able to understand emotion in other people and how that impacted their interpersonal relationships for success in the future. Clearly a 2-generational model program because this intervention focuses on both the woman and her baby prenatally through the first 1,000 days of life. So what we learned from the Memphis trial in particular around maternal mortality and morbidity, which is the reason I wanted to share with you this program, is that nurse-visited women in that model were 8 times less likely to die from some external cause. So women that were nurse home visited were even still 3 times less likely to die from any cause of death. That may include an illness, pre-existing condition, an accident, but specifically around women who were profoundly safer being visited by a nurse, we saw this impact around suicide, like we've talked about today, and maternal mental health. We also saw it around the impact of intimate partner violence, homicide, accidents, and the medical reasons that women die. So we saw that all of the reasons that women have close misses or death outcomes in delivery that you've learned through this committee, like hemorrhage, hypertension, preterm births, closely spaced subsequent births. We saw a reduction in all of those factors through this clinical trial. So what I'll say in conclusion about those findings, and I'm happy to share more material about that, but I want to be cognizant of time today, is that sorry, I lost my train of thought. But what I wanted to say is that we know that this is just one domain where we saw outcomes in the woman and the baby's health. And the second thing is that the foundation of this program is to focus first and foremost on improved prenatal health and birth outcomes. And so we certainly see those here and then in other areas. What's important about addressing maternal mortality and morbidity, particularly in states like Louisiana, where I was at, in Georgia, where we're also involved in working, is that women who are most vulnerable to the adverse effects of social determinants of health see a number of factors impact the health of themselves and their baby at first pregnancy especially. And so the role of the nurse, particularly in this model, which I imagine you may want to have, ask some questions and have more discussion about, is to be able to screen prenatally, but also to be able to offer protective factors through a very trusting relationship on regular visits and safeguard her from the negative impacts that come from societal factors, environmental factors, factors that may be outside of her control. And so we see response there too. So let me tell you a little bit about the facts about the program and why we're talking about it for Georgia. Nurse-Family Partnership is implemented in one county currently in Georgia. That's in Houston County, Warner Robins. We're based in the health department. I've already spoken with Dr. Birkin and said we should connect because we're essentially doing really similar work through the lens just of maternal mental health, just a few miles away from each other. So there could be some really great promising collaboration there, but our site in Warner Robins is funded through the Department of Public Health with federal home visiting dollars at $400,000. They are above their funded capacity, which is 100 mothers. They're serving 105 mothers today. That number has grown significantly. In short, the site in Georgia performs better or at and mostly better than all of the national averages of how nurse home visited women perform across the country. The site in Georgia is top notch. They do great work. They're working with women through a really trusting system of referrals, and they're responding to women quickly when they get referred, and they're enrolling them, which means having a visit right away, quickly, and then they're doing all the right things to implement the program with fidelity so that the outcomes that we know from research will also be achieved in real time. So they're doing fantastic. States around you, if you're curious, the yellow on the map indicates where Nurse-Family Partnership is implemented in other states. You'll see on Alabama to the left, those counties I mentioned through the governor's funded infant mortality initiative are there, and Macon and Russell next to Montgomery. I think that's a really compelling idea to think about, and being able to serve women who may live across the state line in Columbus, which is for Alabama families, the closest delivery hospital. South Carolina is a really interesting example because they are currently scaling from 1,200 women to 3,600 women through a Pay for Success program that utilizes social impact bonds and a Medicaid waiver to cover the cost of those home visits with a nurse and to be able to identify and reduce a number of maternal and child health factors, including but not limited to mortality and morbidity. And I don't have Louisiana there, but I mentioned before that Louisiana is doing a lot of work around this issue with the Nurse-Family Partnership model, and we're scaled in every parish there. So the next slide will show you just a little bit about how the numbers are small. That's how many women are served in each state. But I think the list on the right may be compelling to you because these are all the public funding streams that support Nurse Family Partnerships implementation. I mentioned here we're funded with MCV dollars. It's a weird acronym if you're not familiar, but these are federal dollars reserved for evidence-based home visiting, of which Nurse Family Partnership is one, using bachelor's level nurses. Not all home visiting programs seek to provide prenatal health outcomes or use nurses. So we have a unique spot there. Georgia Department of Public Health implements those dollars, and that's who supports us now. All of the states around Georgia braid together at least 2 or more of these public funding streams in order to support implementing a program like this. And I would highlight for you that TANF dollars are a really promising opportunity to be able to invest in a very specifically targeted population utilizing this intervention because of the way Nurse Family Partnerships priorities align with TANF priorities. We're seeing one site implement in Tennessee and growing up to $11 million in spend with TANF in the next year. So that's really promising, and I'm happy to share and discuss further some of these options. But the last slide that I'll share with you is a summary of all of the ways that Nurse Family Partnership is designed to support families, not just through prenatal health, but in improving pregnancy outcomes, child health and development, school readiness is there, and then economic self-sufficiency for the family. I would like to now introduce my colleague that I mentioned before, Nurse Family Partnership graduate Ashanti Duncan, who can tell you a little about her experience, and then feel free to ask us all questions if that's helpful.
Hi, I'm Ashanti Duncan. I live in Centerville, Georgia. When I first found out I was pregnant, I was 19 years old. I was working 2 jobs, Applebee's and McDonald's. And I had just moved out into my first apartment. I was shocked that I was pregnant. You know, I just became an adult. I just started paying my own bills. How could I afford a baby? And the whole process, wow, I'm still shocked. Okay. I'm still shocked to be a mom, but I found Nurse Family Partnership through my sister, who introduced me to Kira, who has been just an angel, God sent to me. The first few visits, they were pretty awkward. You know, I don't know her. She doesn't know me. She's coming to my house. And, you know, I'm thinking a nurse, yeah, she's probably going to poke and prod me like they do at the doctor's office. But, of course, she didn't do any of that. She just came with her books and her knowledge. She helped with sleeping techniques. She helped with breastfeeding, how to wash hair. You know, as a first-time mom, you think, I know how to do all this stuff. I babysit all the time. No, you don't. And, you know, you quickly learn that from the lessons, but also, you know, through the journey. But I think the most important thing Takira has taught me is probably just to be ready and stay ready, from, you know, the preterm labor to having a little boy who was underweight, and, you know, he grew so fast. I don't know.
How old is he now?
He's 3 now.
Okay. Doing well?
Yes. Takira has helped a lot with that. When my water broke 4 o'clock in the morning, I called her, and you see it on TV, and it's kind of like water everywhere, gushing and stuff. It was nothing like that. I called her, and I was very concerned because I could not stop peeing. And, you know, that's things that the doctors don't tell you, things like that. And that's what this program prepared me for, to have a tool that I could rely on. I could go to the doctor and, you know, they'll say, well, do you have any questions or concerns? No, I don't. I'm a first-time mom, you know. Whereas Takira, she comes to the house And she says, well, I've noticed this has happened. Like my son, maybe he was walking a little bow-legged or, not stacking blocks straight like a normal child his age would. And she'll say, well, ask the doctor, is this okay? Is, him eating this amount okay? Just little stuff, things that it's not a concern to me because I wouldn't know any different. But someone who's experienced and, can see these things, I don't know, I feel like I wouldn't be here. There was this one time where we had 2 deaths in my family at the same time. I have a very strong support system, don't get me wrong, but I lost my grandmother and my uncle within a month of each other, which, my mom and my sister, those 2 are my rocks, and they were crumbling. And I don't think I ever told Takira this, but she saw me when nobody else did, and she noticed that, yes, you just had a baby a year ago. Yes, you seem like you're fine. You go to work every day, you go to school, but something just doesn't seem right about you. And I think that's what this program is. It's a bond that you really can't get anywhere else. I don't know. She's family now. But if I could tell you anything about this nurse-family partnership, it's that more mothers need this program. Because, yes, doctors are nice to have. Yes, family is nice to have. But there's an unbiased person here to help me, to let me know that even if I'm not doing what they're telling me to do on social media, or, if I do things a little differently than what my mom said they used to do back in 1996, that I'm still doing a great job.
Oh, back in the dark ages.
I'm still doing a great job, and it has helped me to become a great mother to not only my son Justin, but to my daughter Ashlyn. It has helped me build a relationship with my son and daughter's father. We're now married. It's kept me going to, be in school. I just graduated with my master's in project management.
Good, congratulations.
And I just purchased my first home at 23.
Wow, way to go.
So I am thankful for these ladies.
Well, thank you for coming to talk to us, but also thank you to the young lady, as a nurse, an RN, and we are talking about RNs, not nurse practitioners. We're talking about good old-fashioned RNs. I think we have a special place in teaching and forming relationships with people. I want to know, back to when you were pregnant.
Yes.
Okay. When, besides just, being basically a friend and somebody who had a lot of knowledge and could impart that to you as needed, were there times that you talked about, like, not eating too much salt, or did you run into any problems like that, or the kind of things that you might have? There are some things that African American ladies do have a tendency to have more than Caucasians that could lead to problems in pregnancy. And so was there a lot of that mixed in with the friendship discussions?
Yes, she broke my heart, and she took ramen noodles out of my diet.
Okay, see, there we go. All right. And I bet you look at salt content now on packages.
Yes, she said, you know how much sodium is in those noodles? And I'm just heartbroken because, we were raised on ramen noodles, and to hear that they're so bad for you, and they actually led to my feet and my legs swelling. So, she helped me increase my water intake and, keep my feet elevated. She would come over and she would just say, are your feet swollen? And of course I say no. And I know I've had a bowl of ramen noodles, but I just say no. And, she took them out the house.
Okay, I thought there might, because that could have caused you some real problems with preeclampsia or some other problems. So,
So
As a nurse, some things we do talk about is hypertension, because we want to make sure you don't get preeclampsia. We're going to stop you from getting to that point. Our clients who are more at risk for gestational diabetes, we'll talk to them about that too. Try to change some of your diet so that when it does get to 24, 28 weeks, then you know, hey, maybe you're not gestational diabetic like you would have been if we weren't in the home. We talk about SIDS. We really educate on SIDS because, you know, that's coming out. It's coming out a lot. After they have the baby. Yes, sudden infant death syndrome. I'm sorry.
No, it's my hearing.
Okay,
because it was coming across as seeds. It's part of that, you know, being of an older generation than 1996.
So yes, and then another thing we talk about, like infections. You know, infections lead to preterm labor. If you have an infection, okay, go to the doctor, take this full 7-day course, because some people feel better after 3 days and they don't want to finish the medicine. But you didn't kill all the bacteria in there, so you know you need to finish taking your antibiotics for that. You know, so we're just doing little health tips that, you know, I'll call the doctor and it might take them a couple days to reach back to me about what's going on versus me. You call me right there. And I say, oh, hey, how about you try doing this? Or how about you try incorporating this? Or, you know, some stuff like that. That's what we'll see. So,
Okay,
yes.
well, and I'm curious about it. I mean, one of the things that I'm hearing is that there's on social media, and to not get me started about how that's not a good thing, you know, that you'll hear often the opinions, oh, you know, if you go to a doctor, they're going to induce labor, you don't want to be induced, or they're going to do a C-section, or do you and your colleagues pick up these kind of, is there a fear of going to the physicians or a hesitancy of going to the hospitals, or?
It's a fear of being in labor in general, especially among the Black community, because, you know, it's a lot of Black mothers dying in labor, and people are scared. My clients are scared. Oh my God, I don't know what to expect. So I want to prepare you. I have a background in labor delivery before I started doing nurse family partnership. So I'm telling
If we get the midwifery program started down in South Georgia area, could you apply to go?
I definitely would.
Okay.
I definitely would.
We can get it down there where you can still work and go. Okay, we're working on one.
When you're ready, let me know.
Okay.
But yes, we prepared them so they know what to expect. I had one client, she was bleeding a lot, but she knew to tell her nurse once she was in the hospital, hey, you know, my nurse told me, you know, my clot should be about this size, but I think they're a little bigger. I'm not sure if it's an issue or not, but at least I'm saying it and I'm addressing it. So she's like, oh yeah, we bleeding a little bit, you know. They worked it out, massage your fundus a little bit. And she was good because she called me and I was like, you know, you got a nurse at the hospital. But, you know, I guess because they have a bond with me because I was there the whole time prenatally. So I guess they have a bond to call me. So, you know, yes, we educate all this.
Well, and I think that let me make this clear.
Yes.
One death of a mother is too many.
Yes, it is.
No matter Caucasian, Hispanic, African American, one death is too many. But I hope that, is it just an exaggerated fear? I mean, we had 100 and we're talking about 3 years when we have the last statistics. There were 130,000 deliveries or something, or in 1 year, 130,000. And if we had 30 deaths, I mean, here again, one death on anybody is too many. Mm-hmm. But given if you have 130,000 a year, that's not a high percentage. Has it been exaggerated through, or is just
social media is a thing, and people are spreading information's getting out quicker, and it might not always be accurate. Go ahead. Yeah.
I don't think the fear is actually of dying. I think the fear is of leaving a baby behind. So what we don't want to do, like my first time giving birth, I was scared to death. I am afraid of hospitals. I am afraid of doctors. They make me nervous. So what I don't want to do is leave my child behind to be raised by my mom, my sister, and, you know, I built this bond with this child that this child doesn't have the same bond with me because I'm not there. And we don't want to make a mistake of not knowing something that could have been prevented, you know, and we're just gone.
Let me let other people ask questions because I've dominated and I didn't mean to. Representative Stration.
I
Thank,
also,
thank you, Madam Chair. Oh,
Go ahead. Hold it.
sorry, go ahead.
Go ahead.
Takira also let me know that I could do a hospital visit, you know, beforehand, which it did help me a lot because I didn't know that you could do that. I didn't know about pre-registration. I didn't know about any of that stuff. And I think that also helped with my fear a little bit more, not just knowing that she was there and that she's worked there, but just having that tour myself.
And see the environment.
Yes.
I really appreciate the testimony today. Thank you for all you've shared. And we have a 3-month-old at my house, and I know how during pregnancy there are some things where you just have questions you just don't know, and just to have an expert to talk to, I'm sure is very helpful. Forgive me, I'm not familiar with the program. Can you just describe to me the frequency of visits, how many times visits maybe occur after birth as well? And then it seemed like there's been a long-term relationship between you, and if that's common and frequent.
Okay, so nurse family partnership, we see pregnant mothers until they're 28 weeks. That's our cutoff limit. So we see them from 28 till the child turns 2. And in the first visit, we're seeing them every week to like establish a relationship and see where they are medically, any needs that they have, anything that we really need to refer them to right now. We see that then. We see them every 2 weeks until they have the baby. And then once they have the babies, like, I forgot everything you said. So we coming back every week to like re-educate you, making sure everything's okay. You know, people go back to work after a month. You know, the family support that you would have there, they're going back to work, where we're seeing you every week for 6 to 8 weeks after that. So then we're going to talk about, you know, making sure pregnancy, closely spaced birth, make sure, you know, you try to get on some birth control or safe sex topics, education like that. And then we see them every 2 weeks until the child turns 2. So we're in the house pretty much pregnancy till the child turns 2, very often.
Dr. Ray.
Thank you, Madam Chair. And thank you for your testimony. I really appreciate hearing your story and certainly seeing the bond that you've created. My question really is more related to how many clients you would have at any given time, and you know, sort of, it's invaluable to be able to go into someone's home. There's just no question about it. I mean, I never get that kind of insight into whom I am actually taking care of by seeing them in my office. So I really appreciate that, but I'd like to know how many people you actually are taking care of at a time.
So currently I have 30 clients. I think the majority of us have up to 30 clients, and it's 4 of us.
It's about right.
Yeah, so yeah, we have like up to 30 clients.
And the model is designed for 25 clients to be the caseload for nurses, up to 30 clients, like Takira said, and that's standard element of fidelity. Is that helpful?
And I see sorry, one more question. I see that there's a long list of funding sources. What's the predominant funding source for the visits?
Do you mean across the board?
Mm-hmm.
It varies. Yeah, I mean, state by state, entity by entity, nurse family partnership is implemented sort of in a franchise-franchisee relationship. So if an entity wants and has the expertise to be able to work with, employ bachelor's level nurses and implement the model with fidelity, I mentioned there are 21 elements that have to be met so that the program is delivered to women in the exact same way anywhere it's delivered across the country. And so funding sources can range from a combination of local, I'll give you Birmingham, Alabama as an example, local health department funding, braided in with the federal home visiting dollars, braided in with, they have 2 new funding streams. One is another state agency that's funding the growth of the model, and then the 4th element of funding comes from, sorry, forgive me, the state's Medicaid coordinated health entities are using essentially their slush fund to be able to invest in community programs, and they're using that to pay for a nurse, up to 2 or 3 nurses, depending on cost valuation and service area. And so they're using those dollars to put specific nurses based in health departments to serve counties that don't have those resources, particularly counties that don't have strong maternal health resources. And all of those funding streams are braided together to support that entity to hire, pay for, educate, and implement those nurses delivering the service for those women 25 to 30 at a time for 3 years.
Okay.
So
Does that make sense?
Yeah, as far as variability, I mean, is it ultimately paying for an FTE to actually go in, like a nurse to actually go into the home versus the number of visits and that kind of thing?
Yeah, exactly. So all of the elements of the program are baked in. So when you estimate cost of adding more nurses, you're essentially baking in, if you use a team of 4 nurses at a time, which serves 100 to 100 and however many moms, you're baking in the cost of educating her with an additional 100 hours of proprietary program education on top of the expertise she brings as a registered nurse. Mm-hmm. And then the cost of her salary, her benefits. What does it cost for her to have a spot where she brick and mortars once a week to do data entry? Evidence-driven program, tons of data. We have our own program, proprietary data collection program with outputs. And so other than that, then she's driving and doing windshield time depending on the territory of the women that are part of her caseload. And so those costs are pretty basic and simple, and all that's baked into estimating the cost of the program.
Okay, thank you. Last question, Representative Stovall.
Thank you, Madam Chair. This is a follow-up to the question about how many patients does the nurse see. And I know you talked a little bit about the how often, well, the frequency, but how often are they actually seeing the patients a week, and about how many clients? So like with Ashanti, how many times did you see her doing? How many Ashantis did you see during the week? And then how? Yeah, I guess this is the main question.
Okay. Yeah, how many do you see in a day? Okay, so usually, I make my schedule, but I'm really flexible around my clients. Cause I work 8 to 4:30, but Ashanti was working, so I worked with her after hours and stuff like that. So I'm really flexible with my clients. So it's not really a certain number a day I see depending on their schedule. I can see up to 5, but I don't want to burn myself out either. So I probably see 3, 4 a day and give myself Monday to put in information in the computer.
I have a follow-up question.
Okay.
Mm-hmm.
And so about how long, as far as how many hours are you spending with? I know it might kind of vary, but is there kind of a estimated amount of hours that you are spending with each client when you visit?
So each client is an hour, hour and a half. So each visit is an hour, hour and a half. And depending on what's going on with that client at that situation, it might go from an hour and a half to 2, It's just depending on what's going on. But typical visits are an hour, hour and a half.
Okay. Thank you very much. It's especially, I appreciate you coming. You're not a new mother anymore with a 3-year-old, but hearing it from a mother that's experienced the program is better than either one of them, anything neither one of them could say. So thank you for coming home and making the program real for us. It sounds like whatever we could do, we could use some more of the programs in different counties in this state. So thank you, ladies.
Thank you.
Let's move on, and we are going to run late. We have Dr. Kenneth Bronstein. Dr. Bronstein is a hematologist and practiced at Northside Hospital. And, we've heard from our universities, and I thought since Northside delivers probably the greatest number of babies in the state, and Dr. Bronstein was there for many, many years, and as we've talked about, many physicians will see one of these complications that lead to death or to serious problems in a practice in their whole practice career. Dr. Bronstein has certainly seen a great number over the years, and so he's here representing himself, not the medical association or anything, but a practicing physician who's had lots of experience. So Dr. Bronstein, you've got it. We just have to stay on. We're here and we're running late, but you go to it.
Thank you, Madam Chairman. You've asked for suggestions what can be done to change the morbidity and mortality of labor and delivery and maternity in Georgia, and that is what I'm going to talk to you about.
Okay.
So imagine yourself to be a farmer, and you got a big haystack, and in that haystack is a needle. Your job is to find that needle. And that is the problem that we have right now in obstetrics, is that the vast majority of women are going to do well no matter what we do, but there's going to be a few that are going to get into real trouble and a few that are going to die. And what we have to do is figure out how we're going to find those women and how do we prevent their deaths. We're going to discuss 5 major causes for mortality. Of interest is the fact that 60% of these pregnancy-related deaths are deemed by the CDC to be preventable. So one of the things we're going to talk about is how do we prevent those deaths. You can look at mortality in obstetrics into a pie chart. Third of the pie chart is going to tell you they're going to die before delivery. Third are going to die during delivery. Third are going to die after delivery. What's of interest is the fact that after delivery now is getting longer and longer. That we now know that when you look at a year, that may not be enough. That there are cardiovascular consequences of going into preeclampsia that can last up to 9 years later. We have 8 suggestions for you that can be implemented in 2020. Except for one of them, they are cheap. Let's talk about cardiomyopathy. It is the leading cause of death and morbidity in pregnancy. If you look at it as a direct and indirect cause of death and morbidity, it's 23% of U.S. maternal deaths. On the left, you see a normal chest x-ray. On the right, you see what a heart looks like when the patient has cardiomyopathy. Wow. The issue with cardiomyopathy is how do you find that patient early? It's very easy to treat a patient once you know what they have. It's hard to know what they have before they're overtly there with it. A test that's readily available and cheap, called BNP, can be done to help out in this area. When you have heart failure, your BNP level goes up. It's a response of the body to having extra fluid on board. And the BNP does 3 things for you, one of which is it causes you to have your blood vessels open up so your blood pressure goes down. It decreases the fluid pressure around the heart, and it causes the patient to urinate. It causes it to be a diuretic. This causes a person who has fluid overload from heart failure to get out of it on their own. It's a simple, readily available test. It's been found, though, that in African Americans, they don't have a normal BNP level. African Americans run a lower BNP level than do other races. And that's both in what's called the NT-proBNP, which is a precursor to BNP, and in the BNP itself. And it's felt that this may be one of the reasons why African Americans may have higher risk of hypertension and its sequelae. And one of those sequelae is pregnancy-induced hypertension and preeclampsia. This test is not only readily available, this machine can be in any doctor's office and can run the test in about 15 minutes. This BNPs have been looked at in pregnant women and is found to be a very interesting test as far as predicting who's going to get in trouble and who isn't. Now, I have to caution you, from here on out, when I talk about normal values, they have not looked at what's normal for African Americans and what's looked at the rest of the country. They've all been lumped together. It is not clear whether or not these normal values apply for African Americans, since we know that they run a lower level of BNPs. But a BNP less than 100 is associated with a 0 chance of a woman getting into an adverse cardiac event during her pregnancy. A BNP greater than 100 has a 100% chance for identifying women who are going to have a clinically adverse cardiac event. So a cheap office test can tell you who's going to be at significant risk and who isn't. Not only that, BNP levels do not vary very much during a normal pregnancy. But people with preeclampsia, the BNPs start going up. And they remain elevated for 3 to 6 months after delivery. And that's important because that may be part of the reasons why you see some of the issues in postpartum patients. Median BNP levels have been established. And they're what's known to be a median for a normal patient, for a mild preeclamptic patient, and for a severe preeclamptic patient has been identified. What is looked at in what's called peripartum cardiomyopathy, which is a cardiomyopathy occurring around the time of delivery, you found that the precursor NT-proBNP levels were elevated 5 times normal. And in another study, they found that in postpartum cardiomyopathy, the BNP level was under 100 picograms per milliliter in only 4 patients, with a median serum BNP level in these patients of 1,258, with normal being less than 100. So it's a very easy test to tell you who's going to get in trouble and who isn't. The importance of knowing about BNP and heart is that preeclampsia has more effects than you might think. It affects the heart, and it affects the heart for up to 9 years out, it's now been found. And that this can lead to women getting cardiomyopathies after the first year postpartum. And preeclampsia is linked to having peripartum cardiomyopathy. If you look at women who have peripartum cardiomyopathy, 22% of them have preeclampsia versus 3 to 5% in the population who are normal otherwise. And any hypertensive disorder, be it preeclampsia, gestational hypertension, just chronic hypertension, raises the risk of having a peripartum cardiomyopathy 37%. What's of interest is we can predict before you get it that you're going to get it. If you look at the black line, that is cardiac output. That tells you how well your heart squeezes. If you look at the mauve line, that's a combination of prolactin, which is the hormone that causes you to produce milk, and a factor that causes blood vessels not to grow, called SFLT1. We'll get into that one a lot later on.
No.
It's what's called an anti-angiogenic factor.
Don't get too deep for us.
I'm trying
There's
not to.
only one physician up here.
All right. Well, the other one bailed out on me.
Oh, got 2?
Anyway.
Oh, I'm sorry. He's an emergency room physician. Sorry.
All right. Anyway, what you can see in this graph is that the average peripartum cardiomyopathy occurs around 1 to 4 weeks postpartum. There's a peak in the prolactin level and this angiogenic factor level right before that peak. And that you can measure those 2 factors and tell whether or not a woman is going to be getting into trouble or not. Looking at African American women, we found out that they have peripartum cardiomyopathy twice that of what you see in the other races. In Augusta, Georgia, and Dr. Ray has left us, they found there was a 15.7-fold increase in peripartum cardiomyopathy in their African American women compared to other races. Worse for the African American woman is having a peripartum cardiomyopathy occurs later in the postpartum period than the other races, presents with a more severe disease, recovery is less frequent, and it took those who did recover longer compared to non-African American women.
Okay.
But there's hope. Bromocriptine is a drug that is readily available and cheap. It is used for 3 disorders. One is Parkinson's, the other is for patients who have prolactin-secreting tumors, and in patients who have acromegaly, which is a growth hormone excess. It has been found, and I have a slideshow for you that you can get on the internet, there's much longer than this one, which explains the science and the evidence based for this therapy. Now, giving bromocriptine can avoid or avert peripartum cardiomyopathy. The problem is it hasn't been done in enough situations that it has been recognized as being something that should be standard of care, except in one country, and that country is South Africa. In South Africa, they have found this to be extraordinarily useful, and they have been the biggest proponents in the world about using this for preventing peripartum cardiomyopathy. And this algorithm tells you what to do for levels of disease. So my first suggestion for looking for that needle in the haystack is to measure and monitor BNP levels, a readily available blood test for heart issues and preeclampsia. Now, I will make a statement that is my personal bias. I think this should be a screening test done on all women, particularly in all African American women, in the 3rd trimester. I have heart problems, and I can tell you from my own personal experience that I can be completely asymptomatic and have a high BNP level in my cardiologist's office. So you can't go by symptoms, and the American College of Obstetricians and Gynecology agrees with that asymptomatic women can still have heart problems, and they may get worse. And by just screening with this cheap test, you can go in and determine that they are or are not heading for trouble before they get there.
Dr. Bronstein, you're going to have to speed it up a little bit, or we're going to be here if you have 8 recommendations.
Well, I don't want to talk too fast. I can talk real fast, ma'am.
Okay.
All right. Pulmonary embolism are a direct and indirect cause of about 20% of U.S. maternal deaths. On your left is what a pulmonary embolism looks like on what's called a CT angiogram. On the right is what it looks like in the operating room when you're taking the clot out of the pulmonary artery. There is a problem in trying to diagnose clots in women who are pregnant because our routine screening tests to tell us whether or not we need to go to the next step just don't apply. Something called the YEARS algorithm has recently been published in the New England Journal of Medicine of this year, and it is found to be a very reliable way of telling a woman whether or not she needs to go to the next step in our diagnostic criteria. It involves looking for the clinical signs of having a clot in your leg, having a coughing up blood, or having symptoms of having a clot in your lungs. In addition, you measure the D-dimer levels. This is the algorithm that you use. Basically, if you have a D-dimer level less than 500, you don't have a clot. If you have a D-dimer level between 500 to 1,000, depends on whether or not you're having symptoms. If you have an over 1,000 D-dimer and you're having symptoms, you have a clot and you need to be further evaluated. By doing this, you're able to avoid 65% of the pulmonary angiograms done on women in the 1st trimester and reduce to only to 1/3 of the women who began the study in the 3rd trimester ended up needing them. Were avoided. So you can avoid 65% in the early pregnancies, and you can avoid 1/3 of them in the later pregnancies. So my second suggestion is you need to follow the YEARS algorithm with D-dimer levels, also a readily available blood test that can be done in that same machine I showed you earlier, for DVT and pulmonary emboli detection.
Okay, would you have to do this on all women, or is there a predisposition, a high-risk group of women that should
this is just, if they come into the office and say, my leg is bothering me, or something's going wrong with my chest. This is not for someone, not for everyone. This is not a screening test for all women, only for women who come in with a complaint making you think they have a clot.
Got it. Come to the ER. Did you get that straight?
Okay. Actually, try to do it to avoid going to the ER.
Okay.
The next thing we're going to talk about is stroke, cerebral vascular accidents. I'm sorry Dr. Goldstein left, because this really ties medicine and psychiatry together. On the left, you see what's called an ischemic stroke due to a clot. On the right is a stroke due to a bleed. Strokes are not common in pregnancy. They occur about 34 per 100,000 deliveries. While they're not usually fatal, they cause devastating morbidity and a lifelong morbidity. The problem with strokes is, since 1994 and 1995 to 2006 and 2007, they've increased in women who are having babies 83%, almost doubled.
Wow.
Now, I'm going to try to be as least technical as I can be for this discussion, but if I get too high, just let me know that I'm going too high on the medicine. Strokes are not, in general, due to hypertension. Only 20% of women who have a stroke around the time of delivery or afterwards had hypertension at the time of delivery. 80% of them didn't. Gestational hypertension was involved in 22.5 out of 100,000 deliveries. The rest had preeclampsia. And severe preeclampsia was with hypertension was your most risky situation for a stroke.
Okay.
Now, is it due to the fact that we're not doing a good job? No. We're seeing stroke going up in young people who aren't pregnant. In fact, overall, in the last 12 years, there's been a 23% overall risk for young people getting strokes. And if you look at women of childbearing age between 18 to 24 years, 38.3% of them have had an increase. Now, it's something about young people, because folks my age, people over the age of 50, are having less strokes. So what's happened? Well, two things. One is called post-traumatic stress disorder. Post-traumatic stress disorder has been linked to 28.6% of the patients who have thrombotic strokes or ischemic strokes. The VA looked at this extensively in 987,855 veterans, and they are convinced that post-traumatic stress disorder is causing strokes in young people with an average age of around 30. And TIAs, which are strokes that go away and don't last, are equal in men and women. Thrombotic strokes and post-traumatic stress is more in men than it is in women. So that we need to screen every pregnant woman for post-traumatic stress disorder. Now, I've heard a lot of discussion about the socioeconomic issues when it comes to being pregnant. I would dare say living in poverty in the United States is an excellent cause for post-traumatic stress disorder.
Or being abused, being, beaten and abused would be certainly one.
Absolutely.
And the kind of, okay.
What just came out as of about 2 weeks ago is a study that showed that insomnia increases the risk of stroke, and that there's a 10% higher risk in adults who have trouble with falling asleep, staying asleep, waking up too early, or having daytime dysfunction due to poor sleep.
Okay, that gets me.
Now, is there a link between all of this? And it turns out if you look at patients with post-traumatic stress disorder, it's almost universal for them to have insomnia. And if you look at women who are pregnant, 78% of them say they have trouble sleeping. I would bet you they probably all have it, they just don't all admit it. I certainly know my wife had problems sleeping when she was pregnant. And if you look at non-pregnant young people, the risk of having insomnia has gone up 50% in the last 8 years, from 2010 to 2018. Now, why? What's the link? It's all those electronic devices we now have. They are replacing sleep. I have one patient who's a rock star, and all she does at night is text people. Another possible mechanism is the device themselves. The light produced by electronic devices disrupts circadian rhythms and prevents what's called melatonin release. In addition, if you play video games, they just keep you from sleeping. So my third suggestion is, in addition to evaluating and treating hypertension to reduce risk of CVAs, we also must evaluate and treat for angiogenic causes of preeclampsia, once they're FDA approved, which is supposed to happen next month, post-traumatic stress disorder, and insomnia. Now let's turn our attention to preeclampsia. Preeclampsia causes between 5.6% to 11.8% of U.S. maternal deaths. As this slide shows, it's complicated. And I apologize if I go over anyone's head. If I do, just tell me. I am trying to, ma'am. I'm trying to. All right. That's right. Just nudge me. All right. Let's talk about one fact. You don't need to have a uterus. You don't have need a fetus to have preeclampsia. All you need is a placenta. Not only that, it's genetic. And the gene can come from the father, the gene can come from the mother, but it's genetic. If you look at twin studies, there's a 40% correlation between one twin having a preeclampsia and her twin sister having preeclampsia. That's about as close as you're going to get in a twin study. Why? It's due to what we call angiogenic factors. And angiogenic factors is a fancy term to say proteins in the body that cause blood vessels to grow. And when you're having a baby, your blood vessels have to grow in that placenta, and the baby's blood vessels have to grow. And you have angiogenic factors that cause blood vessels to grow, which are called proangiogenic factors, and you have angiogenic factors that cause you not to grow blood vessels. There's a balance. The anti-angiogenic factors, when they go up, block the proangiogenic factors from binding the receptors, so you don't get normal blood vessel growth in the babies and in the placenta. This slide shows that balance. And I'm going to use two terms. I apologize, I have to do this. One is called PGIF. That is a proangiogenic factor. The other one is called SFLT, FLT-1. There's a balance normally. In preeclampsia, the PIG levels go down and the SFLT-1 go up. That has caused a ratio to be discovered of SFLT1 to PGIF. And on the top of this curve is what happens in a preterm lady, and on the bottom is what happens in a term pregnancy. You will see in preterm situations, the woman who's having preeclampsia has this ratio go high, that's in red, versus blue, which is normal, very early on and very steep. In the term situation, there is still this imbalance and this rise in the level in the yellow versus the blue, but it's not as steep and it occurs later. This ratio has been found to be the best predictor whether or not a woman's going to get preeclampsia in the third trimester or not. If you have a ratio of under 38 or equal to 38, you have a 99% chance that you're not going to have preeclampsia the next week. And you have a 95% chance you're not going to get it in that next month. Looking at higher levels, at this ratio greater than 85, it will tell you that 59% of patients presenting in all situations will have preeclampsia coming up in the next 2 weeks, and in the preterm women, a 74%. So it can tell you before the woman has any symptoms, any signs, anything, that she's about to get into trouble. In addition, vitamin D affects angiogenic factors and increases the risk of having preeclampsia, intrauterine growth restriction, and in patients with early onset preeclampsia. Now, African Americans have for a long time been told that they're vitamin D deficient based on their vitamin D levels. That turns out not to be true. African American do not have any more vitamin D deficiency than other people. What they have is a genetic reduction in what's called vitamin D binding protein. And that causes them to have less total vitamin D, but their free vitamin D levels are normal. And so they do not have any of the symptom signs or anything like that of vitamin D deficiency. But if you are vitamin D deficient, you need to get vitamin D therapy to keep you from getting vitamin D deficient. And when you're pregnant, that becomes a problem because you have a baby sucking out your calcium. The problem is ACOG does not have a recommendation as how much vitamin D you should take in a normal pregnancy. But they do say is the average prenatal vitamin doesn't have enough vitamin D. But they don't tell you what you're supposed to do about that. The other issue is, why do African American women have more preeclampsia? It's 2 times more than other races. And by the way, on the longer version of this, the first slide you see is from England. We think we have a problem because African American women in this country die 3 times more than other races. In England, it's 5 times. There are genetic differences between African American women and other races in their angiogenic factors. This is outlined in the longer version. This predisposes them to preeclampsia. Now, we can tell whether you're African American or some other race by the SFLT-1 PGIF ratio, which I'll refer to as the ratio, whether or not you're going to need to be hospitalized or what's going on. And this is not available in the U.S. yet. It will be in front of the FDA in December, and if it gets approved by the FDA, which we anticipate it will be, the assay will be available first quarter of next year. And that same machine that does the D-dimer and does the BNP can do this assay. In Europe, doing this assay routinely saves money, anywhere from 5% in Switzerland to 19% in Great Britain. And that is for every pregnancy. And the reason it does it is it tells the doctor who needs to be in the hospital and who doesn't. And that saving in hospital costs pays for the test. This slide summarizes what you can do with that ratio to tell a doctor what to do depending on how high it is. Now, can we tell a person in their first half of pregnancy what's going to happen in the second half of pregnancy? And the answer is yes. There's a screening test that's done where they do maternal risk factors, uterine artery Dopplers, mean arterial pressure, what's called a PAP-A assay, which is used routinely by OBGYNs to rule out Down syndrome and other chromosome abnormalities, and it's easily available. And a PGIF level can tell you with 95% certainty if someone's going to go on to have preeclampsia later on in the pregnancy with a 10% false positive rate. That's pretty good. But there's even better. There's an assay called PROVOKE-1, which has been linked to recurrent pregnancy loss, preeclampsia, fetal growth restrictions, and premature preterm delivery. It has an 83% chance on its own of predicting some women in the first trimester is going to have problems in the last trimester. But it's not yet approved by the FDA. So until then, we have to go with the PAP-A and wait the PRO-1 to be approved. All right, so we tell you now that this woman's going to be getting into trouble. Can we do something about it? And the answer is yes. One thing that has been done in animals and is going to start to be done in human trials is infusing with pro-growth factors, pro-angiogenic growth factors. And there's two of them that have been looked at, VGIF and PIGF. The PIGF appears to be safer in animals and will probably be the one to be used in the first clinical trials. But there's something you can do today. The technology, the equipment, and everything is readily available right now and is FDA approved for removing lipids. That same technique called apheresis can remove the SFLT-1 from the women. And when they've done it, it has made a substantial difference in women who have preeclampsia. One apheresis, can delay delivery for 8 days.
Is that what they do when somebody says they have too much blood or something and they?
No, that is a phlebotomy. I'll show you what we do. That's coming up.
Okay.
If you do like 4 pheresis, you can delay up to, on a medium of 15 days, up to 21 days before you have to deliver the woman. That keeps you from having preterm deliveries. And except for a mild lowering of blood pressure when you first put the woman on the machine, it's safe. This is how it's done. The blood is taken out of the woman, put into a column. The red cells are separated from the plasma. The plasma gets taken and put through a column. The column removes the SFLT1, and then it's given back to the woman. Better yet, there is a drug that everyone who has heart problems or high lipids gets put on. That's called a statin. And there's one called a paravastin statin that has been found to be safe in pregnancy. And there's now a clinical trial in 1,550 women to see whether or not it does what has been found in limited number of cases, that it changes the woman who have preeclampsia to having less symptoms. So my 4th and 5th suggestions is, pending FDA approval this December, to do the SFLT1 and PGIF levels and the SFLT1 PGIF ratio, which is a calculation, to predict who's at the highest risk of having preeclampsia in the near future. Also, we need to ensure those women who are truly vitamin D deficient need to get vitamin D. And finally, once it's around, allowed by the FDA to do the PRO-1 assay to predict who in the first half of pregnancy is going to have trouble in the second half of pregnancy. In the meantime, we have to do the PAP-A assay. Finally, and I'm almost finished, hemorrhage and pulmonary edema, which are the leading cause of death at time of delivery. On the left, you see a normal chest X-ray. On the right, you see pulmonary edema. Women, when they get pregnant, the body very early, even in the first trimester, starts building up procoagulants, factors to make them to stop bleeding when they deliver the baby. But they also drop their anticoagulants, which are naturally occurring substances in the body to keep you from clotting, to keep your blood going liquid. At time of delivery, there's a drop in one of those factors called antithrombin 3 of 30%. There is a balance, even for women who are having high procoagulants and high and lower anticoagulants, to keep them from getting into excess clotting. They still clot too much, but it usually works. But if anything goes wrong, such as amniotic fluid embolus or an infection, that balance gets knocked out of kilter and the woman goes to what's called disseminated intravascular coagulation. And that's associated with the 25% mortality rate alone. Now, there's a drug called tranexamic acid, which is used in pregnancy now to prevent bleeding, for mild bleeding. It is contraindicated in DIC. But antithrombin 3 can be given to women who are in DIC. And in my 22 years of experience at Northside Hospital, seeing all the DIC that occurred there, we never had a death with it. But what kills women who you stop the bleeding is they go into pulmonary edema. They are fluid overloaded from being pregnant, and then you give them a lot more fluid when you resuscitate them when they're bleeding, and when they stop bleeding, it goes in their lungs and ends up causing them to go into ventilators. And that sets them up for pneumonia and renal failure. In my experience, when you got the bleeding stopped and you stop giving the coagulation factor, if you give 100 milligrams of Lasix, that causes them to diurese and they don't go in pulmonary edema. With that, except for a few exceptions, I was able to take care of all the DIC women at Northside and got them to the hospital within 5 days, which is better than when I started there, was about 3 months in the hospital if you had DIC, if you survived. So my 7th and 8th suggestions is to use antithrombin 3 concentrates in DIC and to give Lasix in large volumes when you stop bleeding and you're finished giving your blood products. These are my 8 suggestions. Thank you.
You're right. Any questions for Dr. Bronstein? I know we've kept him a long time. I guess I would have one. There's some things we can do, but also I guess my one thing is that people need to look at what's coming out in the literature about some of these tests and all to see if the FDA does approve them, the new drugs and all in the new test.
These, I have the references on the slides to the latest literature on everything.
Thank you. Is there any other, I think at the hours, it's not that we're not interested, the hour's late. And I do appreciate you coming and the time you spent on putting the presentation together. Thank you very much. And with that, I guess we're adjourned. So thank you to everybody. Say thank you, Dr. Bernstein.